kind of know it. We'll know if we have quorum to be able to move forward with some of the procedural pieces. But formally, good morning, everyone. We're starting the meeting now. If you wouldn't mind starting the recording, Ashlyn. As always, please note that this meeting is being recorded on WebEx, and this recording will be available on the Mental Health San Francisco website. Ashlyn, would you bring the meeting to order?
I sure can. So, as you know, we do for each meeting, sharing that the meeting is being held by WebEx pursuant to the governor's executive orders and mayoral emergency proclamation suspending and modifying requirements for in-person meetings. This committee continues to convene remotely until we're legally authorized to meet in person, and public comment will be available for each item on the agenda. I'm going to take roll call to establish quorum, and reminder to, if you can and would like to, for connection, turning your camera on. I'm going to start quorum. Member Eisen, I believe, is here. Yeah, Member Eisen.
Here, present.
Member Fields. Member Fields here, present.
Yeah, I'm here. I'm sorry. I'm trying to, nobody else seems to be here, so I've got a lot of work to do, but I am here. Thank you.
And then Member Gonzalez. It's like,
We are anticipating she will be late.
right. Member Hammer.
Present.
And Member Lipton.
Yeah.
And Member McGuigan is going to be late as well. Member Patterson.
Present.
Member Salinas.
Present.
Member Short is also going to be late. Member Wong.
Hi, good morning. Yes, present.
All right, so we do have 7 members, so we do have quorum to continue.
And member McGuigan actually is going to be absent today. He called and said he was absent. So we have 2 absent members. We have Member McGuigan and Chair Lassar, who are both absent today.
And then even without the chair, I'm just trying to troubleshoot whether or not we can vote on this excused absent members, Jen, or should we move forward?
Yes, we should be. So I just want to confirm, Oksana, we can vote even without the chair, right? Because we have quorum. Is that correct?
I believe that's correct, yes.
All right.
Okay.
So per IWG bylaws, the IWG must vote to excuse absent members. And if the working group does not take such a vote at the meeting or at a previous meeting, then the minutes will note that. Any member who misses 3 regular meetings within a 12-month period without the express approval of the working group at or before each meeting will be deemed resigned 10 days after that 3rd unapproved absence. So Member McGuigan and Chair Lassar notified us that they'll be out this meeting. I'm going to call roll call now and ask each member to vote yes or no to those excuses. Member Eisen.
Yes.
Member Fields.
Yes.
Member Hammer.
Yes.
Member Lipton.
Yes.
Member Patterson. Vice Chair Patterson.
Yes.
Member Salinas.
Yes.
Member Wong.
Yes.
Cool. So we do have 7 yeses, 0 nos. We do have a majority vote to excuse their absences. Jen, do you want to take this one? Or do you want me?
Yeah, thank you so much. So a little bit about what we'll be doing today. We have a couple of things that we're going to be listening for understanding. So one is the evolution of mental health San Francisco. We have a quarterly report today from Dr. Cunnin, so we're excited to hear from her. And we're going to be hearing from Soma Rise and MENA Project, both the implementation and some client experience information regarding both of those. We're going to be hearing about DPH's mapping project. This is something that's been of interest to all of you, and so we're excited to have them here to talk about that, as well as receive an update from the December implementation report discussion group. We met in between meetings about this upcoming discussion group, and they're prepared to bring some ideas back to all of you. So as always, we've turned off the chat function for all panelists and the public due to issues of accessibility. For added comments, questions, or concerns, please use the email that we have for Mental Health San Francisco that's listed in the agenda. For those of you who are here attending, we ask that you please take the bio breaks that you need. Take care of yourself. We have a break schedule that'll happen shortly after the new beds and facilities 2 updates, but do take care of yourself. We will need quorum to move the meeting forward, so just please kind of pay attention to your peers so that you don't all step out at the same time. Next slide, please. Reminder of what we're here to accomplish. We show this at every meeting, and this is the design of Mental Health San Francisco with the 4 different domains across the top and who is here to present on those. We're happy to have Dr. Harley Cunnins here, the Mental Health San Francisco Director, Dr. David Pating for the new beds and facilities domains, that's the MINA Project and Soma Rise. We're going to have Ashley Vaughn, Heather Weisbrod, and Yoojung Kim for the DPH mapping project, and our Oksana Sherba as part of the December implementation report discussion group report out. Next slide, please. As we do usually, we are going to have a remote meeting update. Next slide. And what we say every time is as authorized by the California Government Code Section 5493E and the mayor's 45th supplement to her February 25th, 2020 emergency proclamation. This meeting will be held remotely without providing a physical location. The state requires that we submit what they refer to as findings every month. These findings are that the IWG, as a public body, has reviewed the teleconferencing meeting status in relation to the COVID state of emergency. The formal requirements titled Resolution Making Findings for Teleconference Meetings are posted on the IWG website. And by state requirement, we have to review this and record our findings every 30 days. So I'm going to read those 2 resolutions that are noted on this slide, and these will make up the findings. So the first resolution is that the state of California and the city remain in a state of emergency due to the COVID-19 pandemic. At this meeting, the IWG has considered the circumstances of that state of emergency. And the second resolution is as described above. Because of the COVID-19 pandemic, conducting meetings of this body and its discussion groups in person would present imminent risks to the safety of attendees, and the state of emergency continues to directly impact the ability of members to safely meet in person. Are there any questions or comments about the purpose of this or these findings? Okay. Hearing none, we'll move to a vote to approve these findings.
I move to approve the findings.
Thank you. Is there a second?
Second.
Thank you.
It was member Eisen and member Fields, correct? Cool. I'm going to first do public comment and then y'all can vote. Members of the public who wish to provide public comment on this item, call that same number 415-655-0001. The access code for today's meeting is 2482-224-1541. And then you'd press pound and then pound again. I'm going to see if we have any callers. Currently, there are no callers in the queue. I'm going to wait.
We don't need to.
Since there are no callers, I'm going to close public comments and go to the votes. We're going to now vote that we understand and submit to the state the finding that we will not meet in person for the next 30 days. I already got the motions. I'll call roll call and ask each member to vote yes or no to approve. Member Eisen.
Yes.
Member Fields.
Yes.
Member Hammer.
Yes.
Member Lipton. Member Lipton voting yes or no on these remote
I'm sorry,
findings.
yes.
Cool. Vice Chair Patterson.
Yes.
Member Salinas.
Yes.
And Member Wong.
Yes.
Cool. So we do have 7 yeses, 0 nos. We have majority vote to approve those remote findings. I think we now have to approve meeting minutes.
Yeah. Thank you. So are there any comments or changes to the meeting minutes? Okay, hearing none and seeing no hands, why don't we move to approving the meeting minutes?
Move approval.
Was that
Member
Member
Fields?
Fields?
Second.
Was that Hammer?
Yes.
Thank you.
Member Fields and Member Hammer. Cool. Members of the public who wish to provide public comment on this item, call that number 415-655-0001. Access code is 2482-224-1541. And then you press pound and then pound again. And then you'll dial *3 to line up to speak. I'm going to see if we have any callers this morning. Currently, don't have any members of the public with us today so far, but if anyone jumps on, I will call them to begin. All right, since there are no callers, I'm going to close public comment and go to the vote. We already got motions to approve and we got a second, so I'll now call roll call. We're voting yes or no to approve the September 2022 meeting minutes. Member Eisen.
Yes.
Member Fields.
Yes.
Member Hammer. Member Lipton.
Yes.
And Vice Chair Patterson.
Yes.
And Member Salinas.
Yes.
And Member Wong.
And Ashlyn, I know that I saw Member Hammer's thumb go up, but I didn't hear a verbal, so I'm just stating
Yes.
that for the record. Yeah.
Yeah,
thank
sorry,
you.
sorry, I thought I was off mute. Okay.
No worries.
Yes.
Thank you.
All right, 7 yeses, majority vote to approve the September meeting minutes. I think now we have an update from Dr. Cunnins.
Yeah, excellent. So this is a quarterly update. So we do usually shorter updates in between months, but this is the quarterly update, and so we're very pleased to have Director Cunnins here to present to us. Welcome.
Morning, everyone. Nice to be here. Nice to see everyone. I'm just wondering, I know this was a late addition, whether you could share slides or whether there was someone on who can.
Yes, we have the slides.
Great. Thank you so much. Is that the first one?
Ooh, I believe so.
Okay, I guess.
Are these what you need, or was this is this the first one?
Let me.
This?
Okay. I guess let's start from the top. I'm sorry, I had thought that was sort of an overall agenda.
Yes, that is. Yeah, there is an intro slide that's the title slide, and now this is the content slide. There's no agenda slide.
Got it. Okay. Apologies,
Yeah,
everyone.
no, that's fine.
The first thing I'll just say to the committee is been very busy and racing to catch up. So my apologies for not knowing this. I wanted to share some of the key updates in this quarterly update about our recent activities and accomplishments and some challenges. First, I wanted to share with the committee where we are at with the Mental Health Service Center update. We are intending to come back to you all with additional thinking based on your feedback and based on the controller's analysis of the 3 options that you all have heard about: a standalone center, a multi-location center, and a virtual center. And we look forward to really a robust conversation as we move our thinking and potential planning ahead. I also wanted to share with the IWG that we have identified a potential building that could serve as a one-stop place, as a drop-in access point, as a hub of the mental health service center, as well as would serve for office staff for key behavioral health services and mental health SF staff. And we think this could fulfill either a standalone center or a multi-location center. So we look forward, as we further look into the possibility of this opportunity, basically, to speaking more with you all and getting key feedback in the next month or so. Next slide. The next area that I wanted to update the IWG is our recent release of the San Francisco Overdose Prevention Plan, entitled Overdose Deaths Are Preventable. This came out several weeks ago, and wanted to share some of the key highlights from this plan. Just to also let you know that this is very much intertwined with the staff who are working on various MHSF domains, and very much we are thinking about this holistically and in coordination. Next slide. So first, I wanted to update the committee members on where we are at in terms of our monitoring of overdose deaths in San Francisco. As I've shared with this group before, the Office of the Chief Medical Examiner publishes preliminary overdose deaths by month. And so we just actually had September come out, but the latest that you see here are in August. What you will see is that there was what seems like a sustained decline in preliminary monthly overdose deaths starting early in the year 2022, but have sort of since mostly flattened. Next slide. Oops. So let me just go back for one moment. So what I wanted to share with the group is that we are obviously still at epidemic overdose death levels, with much more work to do. In a subsequent report to our overdose plan, another report was issued by a DPH colleague, Dr. Philip Coffin, indicating that once deaths were finalized for 2021, we saw about a 10% decrease in overdose deaths in 2021 as compared to 2020. That is a good that is good, but not enough. And so what we are intending in the overdose plan is to press on with a variety of interventions to continue to decrease overdose deaths, particularly focusing on racial disparities. As you recall from past presentations, Black African Americans in San Francisco are more than 4 times as likely to die of overdose deaths than other San Franciscans. So one of the key metrics for our overdose plan is to reduce these deaths by disparities in deaths by 30%, and see an overall decline by 2025 of 15%. So we will come back to you as we fill out our implementation, and in the next slide, will sort of also share the ways in which our implementation of MHSF can assist in working on these reducing and saving lives from overdose. Next slide. As you heard at the top, we wanted to also share overall key citywide progress under mental health SF to date. We have to date opened more than 250 new behavioral health residential care and treatment beds under our domain, new beds and facilities. This includes most recently Soma Rise, which opened 24/7 in the month of September. We have expanded hours at our Behavioral Health Access Center, the office-based buprenorphine induction clinic, both of which are currently located at 1380. Those are the most recent hours expansion by DPH-led facilities. Though OBIC, I should just add, is a UCSF program housed at 1380 Howard. Additionally, the BART Market Street Clinic has expanded hours of patient admission into their opioid treatment program. Their hours now extend till 10 p.m. Weekdays and have weekday hours as well. As is well familiar, we have established the street crisis response teams and the street overdose response teams, or SORT. This includes more than 1,800 calls handled by SORT, the majority of which involved an overdose. We launched the Office of Coordinated Care within Behavioral Health, and you've heard about that program. We have made medications for addiction treatment and links to contingency management at Zuckerberg San Francisco General Hospital, more widely available with some key Prop C investments. And we have expanded behavioral health pharmacy ability to deliver buprenorphine to high-risk housing locations and areas without pharmacy retail pharmacy access. All of these expansions will help us address the overdose crisis. Next slide. And I said most of these points here. I want to just really acknowledge, however, our guiding principles, that we are really building out on many successes that have been achieved by advocates in the city, community organizations in the city, and importantly, people who use drugs themselves. So building on this important work and really many of the strengths that have already been widely known and available in San Francisco, we are seeking with our overdose prevention plan to expand the continuum of services, including both treatment and harm reduction approaches. We are aiming to be driven by the evidence base and the science, but also recognize and incorporate flexibility and innovation that are needed to address the latest surges, particularly driven by fentanyl. We sought in this plan input from community members, providers, advocates, DPH staff, interviews in the Tenderloin, and the guests at the TLC, as well as experts nationally and regionally in drug policy, research, and social sciences. Next slide. I mentioned this already, but I am putting this slide up to show graphically the rate of overdose deaths that you can see on the right. These are 2021 data of Black African Americans as compared to white San Franciscans, Hispanic and Latinx San Franciscans, and other San Franciscans, to show you the profound racial disparity. I also want to highlight that between 2020 and 2021, people who are Latinx experienced the highest increase in overdose deaths. And so that is a group that we are eager to reach as well. Next slide. So our 4-point overdose prevention plan includes the following items you see in front of you, aiming to increase availability and accessibility of the continuum of substance use services. We are aiming to strengthen community engagement and social support for people at highest risk of overdose. We are aiming to implement a whole city approach to overdose prevention, meaning including our city partners who are also touching and have relationships with people at risk of overdose. And finally, we are aiming to strengthen our ability to track overdose trends and related drug use metrics to measure both our successes as well as use these data to inform program development and change. Next slide. And so I want to walk the group, the IWG, through our 4 strategic areas in order to describe to you some of our plans. And again, I really want to highlight that we canvassed carefully the work of Mental Health SF, as well as work that's being carried out or proposed to be carried out by other parts of DPH and other city partners in order to strengthen and be additive to what we are doing and avoid and to address gaps as well as avoid duplication. So the first point is we are aiming to increase availability and accessibility of the continuum of substance use services. And I just want to make a note for this committee, as all of you know, treatment and harm reduction services have historically been viewed as separate and mutually exclusive approaches. We are really aiming to support the work and people's engagement in these services as existing on a continuum. We are aiming to make services readily available along this continuum. To achieve this, we are aiming to establish wellness hubs as a cornerstone of the city efforts, aiming for these hubs to provide overdose prevention services and resources, other services to improve health, linkages to formal substance use disorder treatment, as well as mental health treatment. We are aiming wherever we can to continue to expand access and remove barriers for treatment of opioid use disorder. And you heard in the MHSF updates the many ways that we have done this in the past year to year and a half and will continue to do so. We are aiming to prevent overdoses from being fatal by supporting and broadening overdose prevention services, including naloxone, fentanyl test strips, drug checking, and when legal barriers are removed, safe consumption sites. We are aiming to continue to improve post-overdose outcomes by enhancing overdose response teams and continuing to work to connect people to care. Next slide. In strategic area number 2, we are aiming to strengthen community engagement and social support for people at highest risk of overdose. Without increasing the social supports provided to people via outreach engagement, we will have limited success and the risk of overdose could remain high. To address these challenges, we are aiming to establish or expand communication to the public about drug use and the continuum of services available, including public messaging campaigns. We are aiming to conduct public overdose response trainings and naloxone distribution using a citywide data-driven approach, and aiming to deepen our collaboration with community organizations, as well as developing new partnerships to support people and populations most affected by overdose. Next slide. In strategic area number 3, we are aiming to implement a whole city approach to overdose prevention. We know that the magnitude of this crisis, which is not San Francisco's alone, I just want to add, this is really both a national and local problem. This necessitates a whole city approach in which overdose prevention initiatives can exist in all departments, cover the city geographically, but with appropriate prioritization of most hard-hit areas, but are tailored also to meet the needs of diverse communities, with the goal of reducing disparities, as I mentioned. To achieve this, the city will establish protocols for first responders to refer and rapidly connect people who use drugs to health resources, overdose prevention services, and drug treatment. And I just want to acknowledge both to committee members and members of the public who may be listening in here, we are already doing a fair amount of this work, and we are aiming to strengthen this. We are aiming to make overdose prevention training and naloxone available in all city-run housing facilities. And finally, embed overdose prevention resources in a range of settings to meet needs of people who use drugs such as in social services, higher education, entertainment venues, and potentially other sites. And then finally, as you heard about in Strategic Area 1, we are aiming to promote low barrier street-based services and sufficient drop-in spaces available throughout the city. And again, this is work that really builds on and potentially expands pre-existing work where we have found successes. Next slide. And then lastly, in Strategic Area 4, we would like to improve our ability to track overdose trends, related drug use metrics, to measure both successes and inform program development and change. As you all know, fentanyl is really a crisis here, and you can see the data point between 2015 and 2020, deaths involving fentanyl in San Francisco increased 4,600%. This illustrates the rapidity with which the drug supply and drug use can change. And we know that data can and must be used to inform and evaluate service delivery, policies, and resource allocation, and importantly, to advance racial equity. To achieve this, we are planning to centralize data collection on a number of drug-related metrics, including fatal and non-fatal overdose, and use data to improve our programs. We are aiming to develop materials to communicate these data, including a publicly available dashboard to track important citywide metrics. And finally, regularly meet with community members and frontline staff of service and other advocacy organizations to review data, discuss findings, get input and ideas, and do future planning together. Next slide. I also want to add an additional point of context. The overdose crisis has really highlighted for us and for folks who have in the field the imperative of addressing the social determinants of health, which I know this committee is also concerned with. A great amount of overdose prevention work is already underway in San Francisco, and implementing strategies of this plan, we believe, will save more lives. And at the same time, it is essential that our efforts continue to be made to improve overall health and well-being of people who use drugs, which means addressing systemic issues and social determinants of health. And this is work that is underway in San Francisco, both through this committee as well as the OCO committee of Prop C, along with many others. By making a concerted effort to engage people who use drugs, agencies focusing on these determinants, particularly housing, will help to improve people's health outcomes and supporting implicitly and explicitly overdose prevention. Next slide. And so here are our specific goals, and sorry, I sort of bumbled through them earlier and not anticipating getting all my numbers on the slide. So here are our, what we believe, ambitious but realistic goals. We want to reduce fatal overdoses citywide by 15% by 2025. We want to reduce racial disparities in fatal overdoses among Black African Americans by 30% by 2025. And we want to increase the number of people receiving medications for addiction treatment, or MAT, by 30% by 2025. Why the MAT focus? This is something that we have discussed earlier. We know that people who have an opioid use disorder who receive a medication for addiction treatment are significantly less likely to have a return to drug use and to overdose. And we know that along with other interventions, MAT is really a cornerstone for people who are willing to accept this treatment as part of our work to reduce overdose. Next slide. Additionally, we lay out some key specific goals. In 1 to 2 years, we are aiming to establish at least 2 wellness hubs with co-located services. As you know, and as part of this work of IWG and MHSF, we are aiming to open 70 additional residential step-down beds, 40 new beds for dual diagnosis transitional care for women of the Bayview. As I just mentioned, increase the number of people receiving MAT in 1 to 2 years by 20%, increase the number of programs offering contingency management, which is the most effective form of treatment for stimulant use disorder and is increasingly being found to be a helpful adjunct in people with opioid use disorder. We are aiming to establish a drop-in space with low barrier therapy for people experiencing homelessness, increase naloxone distribution from 47 to 75,000 kits annually, and have naloxone available in 50% of supportive housing facilities. Next slide. In 3 to 4 years, we are aiming to establish, with numbers to be determined, additional wellness hubs across San Francisco in priority areas, increase the number of people receiving MAP by 30%, increase the number of people participating in contingency management by 25%, increase naloxone kit distribution to 100,000 kits annually, have naloxone available in 100% of supportive housing facilities, and train at least 250 people, and we know this is a modest goal, in overdose recognition in naloxone setting, naloxone use in both educational settings and entertainment venues annually. Next slide. And so looking forward in terms of overdose, we believe that the plan builds upon the successful work, as I have been aiming to really emphasize, underway already in San Francisco. And I just want to acknowledge the work of this committee in particular, that we have undertaken together as IWG. We're also aiming to incorporate best evidence. Implementation of this plan will be led by the newly established Office of Overdose Prevention in the Department of Public Health. At the same time, we recognize the ever-changing nature of drug use and drug overdose and how our collective response will also need to evolve. And really, it's through partnership with IWG and other bodies that help us learn and shape and change what we're doing. We will revise the plan annually as new strategies identified and lessons learned, with ongoing input from stakeholders and community members across the city. Next slide. So what I want to just speak very briefly about wellness hubs. As you have heard, they are one part of the city's multi-pronged approach. We are aiming for these to be neighborhood-based programs that are tailored to meet and improve the health and well-being of people who use drugs, with a specific focus on preventing overdose deaths. We aim for these to be a safe, welcoming, drop-in and off-the-street space for people who use drugs to receive care and support. Services will include overdose prevention, access, tight and close access and linkage to treatment, and linkage to housing resources and benefits. We think that this will comprise a crucial intervention to help us address San Francisco's overdose rate and the needs of BIPOC communities that have been unduly harmed by overdose. We are currently developing a pilot wellness hub to aim to transition the critical services offered at the Tenderloin Center and expand on the successes. And we are aiming to open additional wellness hubs in neighborhoods disproportionately affected. As you all know, the Tenderloin Center is slated to be closed by the end of the year, and we know that time is extremely short, and we are working aggressively to try to minimize the transition. Next slide. Okay. Oof. Sorry, I should just add, we were having some internet issues at my office this morning, and so I started off a little discombobulated, but now I'm feeling more settled. So thanks, everyone, and I'm happy to take questions.
Thank you, Dr. Cummins. As we do, please use the raise hand function, and I'll stack you up and call on you as we go. I already see that Member Eisen and Member Fields' hands are raised. So Member Eisen.
Hi, thank you, Dr. Cummins. I had a data question, and I don't know if your data are granular enough for this yet. But in terms of where overdose deaths are occurring, are you able or will be able to capture, are they indoors, outdoors, in SROs, in somebody's home? Because I think that helps us try to craft responses, like where are the hot spots?
Yes, and thanks for the question. I think that's a really important question. We have had, as I understand it, in the city, sort of pieces of those data, and we have them intermittently. Part of our work will be to strengthen our ability to describe some of the key issues, and if there are others, as you all are thinking about this, we're very happy to receive feedback. I think indoors, outdoors is extremely important in what kinds of settings. We do track, and you can see this in the monthly OCME report, both neighborhood of residence and neighborhood of death. So we are going to work to improve those kinds of tracking, again, in order, I think, as you're pointing out, to strengthen responses.
Yeah, obviously, because if they're indoors or outdoors, or if there's some policy or place we should be targeting on indoor overdoses, let's say, that would be critical. And the next question I had was about the drug checking program. So I know that AIDS Foundation has the sophisticated drug checking machine equipment, and I'm wondering when those data will be available. In other words, so we can track like what's in the drug supply, and is there an intent to make that publish a part of the regular reporting, so we get a quick heads up, or are we seeing like what's in the supply, or xylazine, benzodopes, all those kinds of trent dopes, all that kind of stuff that's in Canada. We want to be able to be ahead of that.
Yeah, I think that's a great question. I don't know the answer. I think it's a great suggestion. Let me say that, and it's possible my team is already thinking about that, but I will bring that back to them. I think just for people who are less familiar with this issue, and memorizing, you, I know a fair amount about this, and also is that drug checking can be and is being used in Canada and in some other places, both in the US and internationally, as a way for there to be early warning or early awareness when the drug supply is or has been changing, either by as it was used at first, sort of being able to detect fentanyl in supplies of heroin and other substances, but also with a variety of other substances that can cause harm, and to warn people using drugs, and importantly, support providers to counsel folks coming in for services appropriately. I think that's a great idea, and we should look into that. We also know that drug checking could be more widely available, and that is something we will work towards as well.
Yeah, thank you. I think the one of its best uses is the just general surveillance. So the system preps for what's the best way to respond in the event of an overdose. So that would be great. The final thing, it's more of a comment than a question. I obviously know that the department is in support and very much trying to open the kind of replacement or extension of services or wellness hubs for overdose prevention. So just to the general world who listens to this or participates in this hearing, this is the way I look at it. TLC is slated to close, stop serving in early December, and nowadays I count every overdose reversed as somebody who dies instead of a life saved. I sort of look forward, and that is how I like perceive it and like personally experience that, is that if we reversed 3 overdoses yesterday, those 3 those are 3 deaths, like they're personal. And so I just, with all due haste and concern, I urge the mayor's office and the city to fully support there being no break in service before we can open a wellness hub.
Thank you, Member Eisen.
And thanks for that comment.
So next is Fields, then Patterson, then Salinas. Member Fields.
Thank you. Good morning, Dr. Cunnins. I have three questions that I want to put into the discussion. First of all, I want to compliment the department. I think this overdose plan that is being rigorously developed is probably going to be a national model for the commitment and the creativity and the expansiveness of the approach. So I think we're all going to be very proud of what San Francisco's done quickly on this. And I want to compliment the department on this and include, your vision for how it continues to grow and get more inclusive. So thank you for that. I want to address a couple of things that go back even to the other part of your report as well, which was sort of the update on some of the initiatives under mental health SF. The first is this is the one thing that you mentioned when you were talking about the development of perhaps a building that could provide the one-stop possibility for the services center. You didn't mention the fate of the legislatively mandated urgent care expansion in where it would be housed. It was left out of how this building would incorporate that, or what the strategy would be to meet that requirement if this building actually covers, say, 80% of what we're looking for. Could you say something about that strategy?
Yeah, I mean, what I will say, Member Fields, is that the building is a possibility, and as you can imagine, working through possible buildings, and I don't mean to be cagey about the building, but we're not wanting to name it specifically, is to map out what we can fit in it. As I've learned from my real estate and program planning colleagues, a fit test to see what of the requirements we can meet given the space and constraints of the building. So that is why we are still calling it a possible building.
Mm-hmm. Okay. Yeah, I just, one of the, I think the recommendations coming from this group about that key element of this is probably the most responsive strategy to the urgent care question is the multiple sites one. I just want to make sure it's still on the minds of the department and looking for a way of fulfilling the full complement. It's going to be hard to find any one building will do all those things, so I understand. Second thing
Member Fields, could I break in for a minute? We have a
Yeah.
lot of hands raised and we only have about 20 minutes. So what I'm going to suggest we do is that everybody only give one question, and I'll put you in the queue at the bottom for your remaining two, but just to hear make sure that we have a chance to hear from everyone. I want to make sure that we move through the queue. So please hold your two questions until we have a chance to go through some additional members.
Be happy to. Thank you.
Thank you. Chair Patterson, Vice Chair Patterson.
Yes. And I'd like to thank you for your plan and approaching this very serious epidemic that's in our city and across the country. And I would just like to suggest, and I know it's in your report about community engagement, but to really, search for, talk to groups like NA, Positive Directions, Glide, and kind of involve them in the process if you can. Something I've learned is that harm reduction and the strict approach does not necessarily work together, but I think they should, because I think some addicts, the harm reduction can get them, can lead them to the more strict approach. And I just think if things are disjointed and fragmented, I don't see how it's going to work. There's a lot of veterans. When I mean veterans, I mean veterans in the NA movement that can give a lot of insight into actually reaching the people, because they work with the people day in and day out. And there's veterans that are from the harm reduction approach, and there's veterans that are also from the strict approach of abstinence. And I think, maybe, somebody like you can actually bring those two together bring people from both of those approaches together, and to see if we can kind of use it as a strategy to get people on different levels. Because I mean, I know we try to reduce numbers, but also like in reaching the addict, there's windows. There's windows. There's windows when somebody does want to get off drugs, but it's not every day. And then you have the people that just want to stay for a while. So with that, I'll land the plane. Thank you for hearing me.
Thanks, Member Patterson, and I appreciate, well, thank you, and I appreciate everything you said, and that is our absolute intent, to talk to both people and organizations sort of already working with people with addiction and who use drugs, and also reach people and organizations who don't necessarily identify as this work is their primary focus. Maybe they are doing economic development, maybe they were doing housing supports, maybe they are doing maybe they are faith-based organizations, to really think about this, the community engagement work broadly and deeply, to reach as many folks as possible who care about the people who are dying, the friends and family of people who are dying, to engage them in however we can. And I totally agree with all of what you just said. And thanks for raising these issues.
Thank you. Member Salinas?
Again, I also want to thank you for the work that you're doing on this issue. I think that the wellness hubs are going to be really great for our populations at ICM, particularly because of the co-located medical services. I think for wound care, it's often very difficult to engage some of our clients in accessing wound care and care for other health consequences around IV use. So I think this is going to be very helpful for us in getting our clients this particular needed medical care. I do want to ask a question that's related, but not part of what you're talking about today. And I think it's just wondering if you know what is going to be the fate of Joe Healy, because I mean, we utilize Joe Healy. It's vital if we want our clients, for our clients who are using alcohol and opiates, they have to do medical detox in order to be able to go to residential treatment program, right? DUC can't serve them if they need detox services, and the residential programs can't serve them either, right? So I'm wondering if you can tell us more about the fate of Joe Healy.
So what I will say, so for folks who may be less familiar with this issue, Joe Healy is run by Baker PRC, where there is significant challenges financially happening, and including the potential for transfer of services. So I just want to say to you, Member Salinas, and really to the entire group, that our top priority is to preserve services in this time of transition. We are working very, very closely with Baker PRC and a variety of providers in the city to aim to preserve continuity of care for any individual patients, as well as for continuity of services. I think, as has been public, is one program at Baker PRC. I'm sort of jumping the line for what I anticipate to be some other questions. Is Acceptance Place, which will be assumed by HR 360. And we are working towards a transfer of Joe Healy as well as the other 4 programs that Baker PRC has announced that they would also that they also want to transfer, including Ferguson Place and a program called Assisted Independent Living.
So Joe Healy we will definitely continue to have a medical detox.
We are the city, I am personally, and we are absolutely committed to continuing to have a medical detox of the city. I think as you point out, we would say broadly that this is a service need that that we have, and we will continue it.
Thank you.
Are you feeling complete, Member Salinas? Yes. Okay, thank you. Member Wong, then Short and Fields. Member Wong?
Hi, thank you so much. And thank you, Dr. Kunis, for the report back. I'm going to just kind of feel like a broken record, but I know we have so many people who want to talk, but I just want to emphasize again that duplicating services, and as I'm hearing this, you were mentioning that you guys going to probably need to do or kind of expand more on your interventions on the plan that you guys have. And from what I'm hearing is that there are a lot of services, right? As Member Patterson had mentioned, there are a lot of services that are already existing. And so instead of, keep expanding on something, can we just continue to add on to what we have and enhance what we have? And I know you say we're trying to preserve services, but I really like to see that we're going to enhance and provide even more additional services to existing services. That's why I'm looking forward to the mapping services that we have. And the other thing is, as I'm hearing, it's great. I am totally in support of doing intervention with the overdose, but what about treatment? Where are we going to have continued treatment for these folks? I mean, it's great that we can engage, but how are we going to get these folks in treatment? And I think some of these short-term interventions are great, but what about the long term? I think we need to have a lot more of a vision of how to stabilize maintenance as well. So I know there's more, but I'm just trying to summarize what a lot of the questions I have, and I know we have other people. So yeah, thank you.
Well, thank you, Member Wong, for your comment. I just and happy to talk further about this, and we do have what I think is the beginning of our mapping report. But I do want to emphasize that I don't think this is an either-or plan. For example, adding on hours to the Behavioral Health Access Center, adding on hours to the office-based induction center, expanding capacity to, or adding on service hours to an opioid treatment program are all examples of the adding on to existing services in order to enhance them. Similarly to adding on dollars to intensive case management programs is an example of adding on. So I think in some cases, expanding existing services, and in other cases, starting new services. So I just kind of want to invite you, or that's how we're seeing it, is both adding on in some cases and establishing new in other cases. And it is, we rely on your collective feedback as well as, in the case of overdose, the feedback of additional folks in community to aim to strike the right balance. So I do want to say that. Let me also tackle your comment about the long term, which is we see this plan as aiming to achieve both goals, both near-term interventions that are often termed as overdose prevention, interrupting an overdose, supplying naloxone, supplying drug checking, as well as connecting people to treatment. part of the work of MHSF is importantly, and for example, to add on residential step-down beds. The reason for those residential step-down beds is because so many folks coming into residential substance use disorder treatment may be experiencing homelessness or have unstable housing. And so residential step-down is the longer term, is our building out our system's ability to really extend stability for the person as they are stabilizing in recovery following residential treatment. So I don't want to, I share your concern or share your comment about needing both the near and longer term, and hope that you don't walk away from the understanding of the plan as not being preoccupied with longer term stability and recovery as well as the short term.
Thank you. Member Short and then Fields.
Hi, and sorry, I was a little late. I read the plan, when it first came out, and I was pretty impressed. I'm really happy that DPH has put together this overdose prevention plan. I think it covers a lot of the bases, and I'm eager to see it, implemented. The question I have is actually just kind of a follow-up to what Vitka raised, because I'm super concerned, especially since I work in the Tenderloin and most of our residents live in the Tenderloin. And there's been 400 people a day using the Tenderloin Center. And I go by it every day, twice a day, and there's always a line. And we know that it's closing early December. We know that DPH hasn't been able to find the proper sites to set up the wellness hubs before that. And so I'm super worried about a lapse in services. And so I'm wondering any creative ideas, DPH has about ensuring that those folks, they can be given something, a piece of paper saying, you can go here, and not leaving them, literally out in the cold, and not having it be abrupt either. So some good sort of outreach and education about what comes next, and then also some easily accessible and well-placed resources for them to go to. And perhaps that means just enhancing some of the services that exist in the area that other programs are already doing. Doesn't necessarily hinge on having a literal, physical location, new building or whatever. Yeah, perhaps it means roommating with some other organizations. I don't know. But I just want to know that DPH is doing everything they can to make sure that people are still getting served with all of the needs that are being met at that current location during that period where that'll be closed down and you don't have the wellness hubs up yet. And I'm concerned overall, but would very much like to know specifically for the Tenderloin, because the need is so high there. And also I think because that's kind of where people are used to going for that. And if there's stuff available right there in the Tenderloin, I think it would be all the better. So thank you.
Thank you for your comment, Member Short. I just want to say that we're concerned too, and I think you just listed out some very. I think you used the word roommating. Is that the term? Is that? And I think if
Technical term, yes.
I like the term. Thank you. We are really happy for suggestions and advice, including space. And so feel free to email me any suggestions.
Thank you. We are running 5 minutes over. Member Fields, you'll probably be the last one.
First and the last. Okay, thank you. when we were developing these ideas about addressing the needs of the mental health system in San Francisco, I think some of us thought it should have been called behavioral health SF, but everyone knew that would confuse more people, particularly when at one point it was a ballot measure considered. So it came mental health SF, but as we all know, there's no demarcation between the substance use world and the severe mental illness world when we're looking at our challenges. What I'd like to maybe just raise, because I don't think there's time to go into it in great detail, but when we're talking about this building out of the continuum of care, which is an inherent part of the MHSF legislation, clearly the dual diagnosis world, as for the most part, sits on the public health side of the picture in the mental health side because of the challenges of working with a diagnosis of severe mental illness and ongoing substance use. So in a way, harm reduction and treatment, as you alluded to it, Dr. Cunnin, sits naturally in the mental health dual diagnosis world because that's what we have to do just to be able to reach clients. And we're challenged by two conflicting approaches while we're doing it. So harm reduction is natural for us. I'd like to hear some more when we go down about the expansion of services. That's not just step down on the substance use side, but what are we going to do to expand the capacity for treatment, which most of our clients serve. Everyone that the Progress Foundation programs are being referred now from the hospital have a serious substance use problem and a serious behavioral issue to address. And we're going to have treatment options for that population. And we're going to have to utilize a lot of the approaches that you're describing are being developed on the substance use side. So I want to put in a pitch for discussing the public health department's approach to working with the specialty mental health services that are in essence serving this population every day. So some of the community organizations, the frontline staff you're talking about, I don't know if the outreach has been to the residential treatment system or the outpatient system necessarily on the mental health side, but I know the 24-hour care system could use it. And that's a good place for an interface between these two challenging treatment approaches in those environments. So I look forward to working with the department on that even more as we roll this out. We're looking at the possibility of more overdoses every day in the mental health residential treatment system, because often they're not long-term addiction issues. They're people new to this world, and they're much more susceptible sometimes to being exposed to a world they're not used to. And we could use a lot of that work. And so I hope the frontline organizations you're reaching out to include the mental health side, not just community substance use providers. So it's not a question, it's a request.
Member Fields, thank you so much for raising this. And I concur deeply. And I would say we have started to do some of this work internal to the DPH clinics, such as engaging clinic staff in distribution of naloxone, for example. And of course, when I say distribution of naloxone, it implies some amount of training and overdose education. It sort of brings people who may have historically or by training see themselves as a mental health provider. And as you know, Member Fields, and from my own background, many of us have grown up in silos that we need to break apart. So we have, I would say, begun some of that work internal to DPH and very much, and if I didn't name that as a key audience member or mental health providers in the city who are very much important, critical to the overdose response work. So thanks for raising that explicitly.
Thank you both. We are at time. I know that Member Fields, you may still have a question, and Vice Chair Patterson and Member Short, you may also have some questions. Your hands are still raised. And Somebody else may. So if you do, please contact Oksana or myself and we'll bring it to the city planning team and we'll find a way to route it and get the information back to you. Dr. Cunnins, as always, thank you for coming. You can see you always generate a lot of good ideas and good discussion, and we thank you for giving so generously of your time.
Thanks, and I'll be on and off this morning. Just and particularly for the mapping presentation, we'll be here to participate. So you haven't seen the last of me today. Thanks.
Great, thank you. So Ashlyn, let's go to public comment.
Cool, yeah, so members of the public who have joined us, if you have, should call this number 415-655-0001. Access code is 2482-224-1541. I'm going to see if we have any callers. We do have one caller, so I'm going to unmute them and then you may be in your comments. You've been unmuted.
Hello?
Hi.
Okay, you can hear me? Okay. Yeah, I'm very concerned about this whole thing. You know, getting help is a matter of continuity of care. I worked at the Tenderloin for a few years and, you know, people would come back because they know somebody. Creating these parallel programs is just a real problem. And I know I can't ask any questions, even though the recording says when you're ready to ask your question. But it seems like some of these programs were already up and running like before the group even started. I was on the original planning panel to do this at City Hall. And it seems like, you know, some people are getting their special programs out there without any input. And then we have really important things, you know, like the Tenderloin Clinic that are closing that haven't been addressed. I'm very disappointed in that. That's all I wanted to say. Thank you.
Thank you. I'm going to see if we have any other callers. Currently, no other callers. So I'm going to close public comment. And we are moving to discussion item 4.
Thank you, Ashlyn. Yes, so we have 2 presentations before the break that are updates from the new beds and facilities group. That includes Soma Rise and the MINA project. And first up is Soma Rise. Next slide. Just to kind of organize ourselves and situate ourselves in where we are, the 4 domains are in the blue boxes. We are looking at the new beds and facilities section, and Soma Rise is into this expanding existing models. So we welcome Dr. Pading to present on this item. Next slide, please, Ashlyn. And Dr. Pading, are you there?
Yes, I am.
All
Good
right.
morning, everyone. I was asking to be unmuted, and I realized I was the one that was muted. So I'd like to give you an update, a quarterly update on Soma Rise. We hope to come back to you intermittently about this program, and as well as the next program I'll be presenting, which is the MINA project, to let you know how we're progressing with mental health, SF, new beds activities. So for members who were not here during our orienting presentations on Soma Rise is located on 1076 Howard Street, which is in the South Market or Soma district between 6th and 7th. It's a joint project with the Department of Public Health and Health Right 360, who has contracted with us to provide a safe and welcoming space for people who are intoxicated to both sober or come down from drugs. And our rationale is rather than having a mental health or drug crisis on the street where individuals who are in crisis are not safe and don't feel safe, better to come on in, receive some hospitality, and leave better than when you came in. Next slide, please. So I want to show you a picture of our welcoming staff. the staff really does practice and promote welcoming. I'll give you a story about that when we get farther on. But the idea of radical hospitality and dignity of care. In the right, you see a little bit of our lobby. It's clean, it's professional looking. All the restrooms and showers are clean, and the bedding area is clean, and the staff do smile. Every time I go there, I'm always greeted by staff, and I never fail to hear from people that have visited the program how much they felt really there was a warm but professional environment. And it's this radical hospitality that we've learned from other programs that have practiced this, namely our Tenderloin Center, that have been very beneficial in having people come in off the street again when they're in crisis. Next slide, please. So here is a slide of our arrival data. The program launched on June 27th, and you have here data for the 3-month period ending September 30th. You'll see the gradual increase in the amount of services that were provided and the number of people coming in. We initially launched with 8 hours a day of services. Well, actually it was 10. It was 8 to 8 at night. And then we gradually increased till September 1st. We went to 24/7. And this was partly due to accommodating staff hiring. But fairly consistently since August, we've been having 200 to 250 clients a day, with September, a week, with September us having 1,015 clients. And that's not even including the full week of September 26th to September 30th, which is only 4 days. The average length of stay initially was 4 to 6 hours, but now that we've moved to overnight services, they've been approximately 10 hours in September. And in terms of where clients come from, this was our wish, and it's been proven to be true in our data, that most of the clients have been coming from the Tenderloin and Soma neighborhoods. Next slide. So that's where clients are coming from. Our goal was to also begin to link people as part of care to services. But before that, let me talk about where people go. So we are up through September still on a paper system and are transitioning over to the Epic EHR system. Next time I come to you, we hope to have data from Epic that we can pull and share with you. Until then, we're looking at paper records. So I just want to give that caveat. Paper is paper. Sometimes it may not be as thorough as a computer record, but we have 859 departures documented. 48 went to unknown destinations. This is oftentimes before people or the staff could ask, where are you going? They just collected the things, headed out the door. 14% remained unhoused and went back to the Tenderloin. 30% were unhoused and returned back to the Soma district. And 7% we know where they went. And you can see here on the right side where the 7% went. Some went a very small amount, because there's only N of 58 here. A few, 2 or 3 went to the emergency room or back to psychiatric emergency services. That we have so few that went to the emergency and PS is, for me, extremely high positive, because it really means that rather than many of these clients having gone to the emergency room, we diverted them, and that we're also getting the right clients in who do not really need those emergency services. Several went to withdrawal management and crisis services, where they also can receive a linkage to care. And the remaining went to other housing options, including a sleeping village, some shelters, and an SRO hotel. And then also in this group are a large portion that we do not know where they, well, actually they went to other sites, and the data was not reported to me of where they went, although we have known destinations. So that's the departures, and one of the major goals is to link clients to treatment. And you're seeing with withdrawal management, we did begin to see people moving forward in their course from being on the street, having crisis, and then linking to withdrawal services. Next slide, please. Other services that have been a mainstay of the care there have been harm reduction supplies and snacks. I did not include the data on snacks and food. While we were opening shorter hours, we gave out more food to keep people coming in and to let them know about our services. But the harm reduction supplies have been a mainstay here of both harm reduction kits and Narcan. You'll see in the last 2 weeks or so, Narcan went to 0. We're having some supply problems that have been system-wide. That soon will be rectified. But it's been a steady supply of distributing Narcan on the street and other clean and safe harm reduction supplies. And the more of these on the street, the safer for everyone that's using. Next slide, please. But more than the data, I think the stories I'd like to tell you, and I'd like to share with you 3 stories, I think really give you a flavor of what's actually happening at the Summarize Drug Sobering Center. The first is something that we feel is really important to tell, which is our linkage to the Street Crisis Response Team. The Summarize program was designed to be a service that would complement the Street Crisis Response Team. As you know, the Street Crisis Teams were part of Mental Health San Francisco. You've heard reports on how many clients they've picked up, how many the 7 teams that are circulating the city to identify people in crisis. And one of the things we heard is that we need places for people to go. So this is a street crisis story that one of our teams had received a message from, and I want to share this with you. I apologize for reading it, because that's the best way. Early on Sunday morning, we had a transport and a warm handoff to Soma Rise after a difficult call. The client was paranoid and reluctant to enter, but the staff there came out and greeted him with warmly and reassured him that he was safe and in good hands. Without them coming out and meeting us upon arrival, I'm sure we would have lost the client. This is a story that we heard a month or so back. It's been very typical of the interactions between Street Crisis and the Soma Rise team. The Street Crisis team also has a follow-up function. And so while they've been able to drop clients off and engage with, clients engage with the welcoming services, they also are able to come back the next morning and meet the client and then link them to ongoing care. So both before coming in and after coming in, we've had a wonderful relationship with Street Crisis Response Team, and we meet with them regularly to troubleshoot communications, handoffs, and meeting the needs at certain hours. In fact, 2 beds are set aside throughout the evening and the daytime just for Street Crisis, so there is availability for them and our street overdose response team as well. Next slide. The next story is about a story that has an arc to it from the Tenderloin Center to treatment. So Soma Rise is showing to be a increasingly important connection point for people at various services in the community. I've talked to my friends in the adult probation services and the reentry services, and they've been referring to Soma Rise. But here's a story where a Tenderloin Linkage Center guest wanted to quit using drugs. So, and then this is written by the TLC staff. So our TLC staff took him aside for a brief assessment to understand how to support him. They said he was homeless and worried that if he remained out on the street another night, he would just use again, and he really wanted to quit. So we called Soma Rise and set up an intake. A staff person from Code TL rode in the Community Forward shuttle. Those are 2 of our partners with him to Soma Rise. There he said he had never felt safe and taken care of. The Soma Rise staff provided reassurance and validation. So at Soma Rise, he ate a warm meal, showered, had a bed for the night, He said he had a surprisingly good night's sleep, given that he was about to go to substance use disorder treatment. And so the next morning, a Summarize staff member walked him over to an intake at HR 360, which is just around the corner at 1563 Mission Street. It's about 4 blocks away, where he successfully was admitted that day to the Walden House. And so on the right here, this is a famous sign in front of Walden House. It is, I think, something that is very appropriate for any people that have been on the street and experiencing homelessness into treatment, that today is the first day of the rest of your life. So putting people on their path to care, having Summarize in the middle of that, we consider this a success, and we hope to see more of these kinds of linkage stories. Lastly, the next slide. One of the most endearing stories that we had is from a mother that actually wrote a letter to Mayor Breed. This is in early July, just after the program opened. Her son, who had a mental health disorder as well as substance use, had presented multiple times to the psychiatric emergency services. And on the last few visits, he was taken from the psychiatric emergency services to Summarize, where she felt that he was treated in a way that, you just see here in the second sentence, people talking with him, people who were caring and consistent, yet who set appropriate limits according to the program rules. And that as a result of that, he became mentally present again. He started reading a book now and then. And she felt that these were small steps, but they were important steps, that he began to talk really for the first time in a long time. And that she was just so proud from a mother's perspective that there was a service like Summarize to meet and greet. And I think for me, the lesson of all this is that, meeting people with respect, providing dignity, and the restorative value of rest that's provided when people can get off the street and resolve their crisis before they get arrested, before they get assaulted, before something else happens. This is a really important link in our move towards treatment and services. And I hope to have you tell you more success stories when I come back in the future. So why don't I end there and take questions, or do you want me to pursue the Minna story, Jennifer?
They're agendized as two different elements, so we need to just pause for questions and then public comment. Questions. Member Wong, your hand is up.
Yes. Thank you, Dr. Payne. I mean, I think looking at SOMA, it is such a very nice program. What I was listening to is that you were and I saw the graph or the stats that a huge percent of people who came in, left, don't know where they're going. And I'm just kind of curious of the people who are revolving back. And so if they go and you don't know where they go that first time, if they do come back, how do you continue to engage them so that they can get into linkages and treatment, just like what the scenario you pointed out about the person who actually said, I want to quit, and then he was immediately connected with Health Right 360 and then on into the Walden House. I mean, I think that's great. And so I'm just kind of wondering also that I think some of the members on in the committee had also talked about vocational, right? I mean, you talked about restore of value and dignity. I mean, I think if we talk about that, then I think we need to help these individuals not only maintain their wellness, but how do we help them so that they can feel they are productive individuals, part of the community? And again, if we have this huge number of people who leave, we don't know where they go. When they come back, how do you then engage so that we can make a success linkages to other programs? And I think that that's really important, as you said, restore value and dignity. I mean, that totally just kind of stuck on my mind. And I hope we can do a lot more of that. And to do that, I think, people need to be productive individuals. And that's great engagement, but how do we link? And there are opportunities that we can link. If they come back, that means they want to be linked somewhere, not just come back and go, come back and go. I mean, although it's fantastic, but again, I'm looking at maybe long term. Thank you.
There's two questions there. So with regards to how do we know who came in and where they went, we're still piloting methods to be able to understand, to meet people where they're at. And so the staff is trying to be as least intrusive as possible. So what they've told me is that, some people just don't want to be talked to. I need to go somewhere. And so there isn't enough time to have that conversation upon leaving, but they're getting better at that and they're collecting more information. So hopefully that question mark about the ones that were not known will have better means of gathering that data. Some people just wake up and they want to go. They don't talk to me, I need to get out. The second thing with regards to people coming in multiple times, this is actually a desired goal. When we looked at the Alcohol Sobering Center, which has been around since 2003, the average number of visits to the Alcohol Sobering Center is 11 visits. And over the course of those 11 visits, people gradually decrease their use. It's very uncommon to hear the story of people coming in once and they moving on. So the story I actually gave you from the Linkage Center, I think that's going to be somewhat of an exception. And I would imagine what we'll see is people coming in several times. In fact, we've been hearing this 3 or 4 after the 3rd or 4th visit. They're feeling better and they're ready to consider something. So this coming back over and over again, that's a good thing, because that's how you build relationships with individuals and you begin talking with them. It's not one conversation, it's multiple bites of the apple that really fill you up. Regarding vocational linkages, that is part of the continuum of services that can be provided. If people want to get referred to the Employment Development Department or vocational rehab or Code Tenderloin, we can certainly do that. And we have the shuttle buses to get people there. There's a commitment to make the phone call, to get people on the bus, to make sure that it's a really warm handoff. But I don't think that comes in as a first thing when people come in at 10 at night, just slept the morning, trying to figure out where their stuff is because they left it on the street. I think there's a process here that you engage people over time.
Thank you. Member Wong, are you complete?
Yes, when I was talking about keep coming back, that's what I was talking about, referencing that if they have the desire to keep coming back, they've already connected and made that rapport. So with that connection, that's the engagement and the continued care that's probably where you want to, hold on to, right? I mean, that's I understand that keep coming back is great, but if they keep coming back, then that means an opportunity is there to really link and connect. Yes,
that's where selecting really welcoming, friendly staff is so important. And if you ever come down to Summarize, I would really welcome you to talk with staff, because you see how each one of them is very dedicated in doing just that.
Thank you. Member Short, your hand is raised.
Yeah, I've been really looking forward to the center opening, and I went on a tour and looks really cool in there, and glad to hear the stories. Think it's a great asset. I am worried because I know that it really relies on having good community and political support, and there are a lot of people who are really frightened about it. And there was a recent, hit piece on TV news or something. I don't know what else may have been out there. I'm wondering, I guess, what we can do to sort of counterbalance that kind of stuff, whether it's myth busting, doing more, public education, or getting, good media or positive media, or I mean, just the presentation you have right here is an example. It's good, balance, but, or, just thinking about shoring up a good level of support so that we don't get one of those, hit pieces or whatever, and it just brings it all down, because I've seen that kind of thing happen. And how we specifically, this working group might be able to help in any way with that too. Just kind of, I think particularly spreading the word or having a message about the real kind of maybe public health, aspects of it, because I think people they don't understand some of the other stuff around how important it is that someone just got in for the night and got a respite, but if there are, more things we can share about, for instance, how maybe over time this actually helps link someone to treatment or those kind of stats. Anyway, it's not exactly, it's a comment and a question, again, of like thoughts you have or any ways we can help, but it's also more of a just flagging this that I think this is going to require, ongoing work of putting the positive messages out and countering the negative messages and trying to get people to understand what it really is and not all the myths about it, which is really about, if people aren't clear about the dangers, right? People are making claims that it's, dangerous to have clients there, that they're going to go do dangerous things in the neighborhood. Okay, thanks. Long-winded, sorry.
No, I really appreciate that. And as much as the IWG can support activities like this, and many of our MHSF activities, you look at each one of them, there are people that with many of the interventions that we're doing. But what we like to, our public affairs department is working on messaging. I think currently our message is, we're all trying the best we can to deal with what's a citywide crisis. Summer Rise is one of many novel and interesting, innovative approaches that we are implementing to try to stem some of the trends that we're seeing. But these are new programs that are piloting. So there's a time that we're asking for patients to work them out and for people to come in and look and really learn about what we're seeing and what the stories, because it's really easy to have a sensational story. It's harder to get a story out about success. So again, I'd like to welcome the IWG members short to some of the members that you're connected with in the community and others to visit Summer Rise, to hear the stories yourself and spread them. Because I think data and stories are the way that we'll be able to turn this tide.
Are you still able to do tours? Because you were doing them at first when it was still empty. So now that people are there, is that still some kind of possibility?
Yes. So what we do is we are asking people to come in advance. That we'll have you work with the program manager, Mr. Jose Rios Cortez, and schedule a time. We don't want large groups, but 3 or 4 at a time can certainly visit. Ask you to keep confidential, and but see how the services work and meet the staff that's there. I think seeing it is really the best way to get a feel of what's happening. It's easy to hear stories and make things up, but when you see it, you'll hear why people are saying this is really a wonderful place and it's working.
Yeah, thank you. We're a little over time. Member Eisen, I see your hand is raised. Can you make it succinct?
Absolutely.
Thank you.
Just a general comment, actually, to the groups, to the group members. It's not really a question. I think that we should anticipate, given the kind of the political climate and the community climate in San Francisco right now, that there's a lot of innovative programs that the department is proposing as a part of Mental Health SF. and as a part of the overdose prevention plan. And I think that what we're seeing in terms of the response to Soma Rise, I think we'll see more of that. And I think it's not just the department that has to, I mean, the department is a part of addressing that, but I think we as community participants and as advocates for people who have behavioral health challenges and don't have housing, that we need to be prepared for countering that kind of narrative. So I think there's some people who just, I think, generally believe that nothing's going to work. And I think the city is pivoting to try to do lots of things in an innovative way to make it work. So it's just a general comment to all of us.
Thank you, Member Eisen. Appreciate that. Let's go to public comment.
All right, so those who'd like to provide public comment would call the number 415-655-0001 and the access code for today, which is 2482-224-1541. And you'd press pound and then pound again. See if there are any callers in the queue. Currently no callers, but I'm going to wait a minute. All right, since there are no callers, I'm going to close public comment and we are moving to discussion item 5.
Thank you, Ashlyn. A note about time is that we have, we're running a little bit over, and we have the mapping project is happening after the break. The subject matter experts that are on hold and are waiting in the wings to present do have a tighter timeline. So Dr. Pating and team, IWG team, if we could keep this a little bit shorter, that would be great. Thank you.
Okay, let's go to the next slide, please. I'm going to share with you an update on the MINA project. The MINA project was one of the 250 new beds that we built. Next slide, keep going. It's located at 509 Minna Street and is a joint department between the Public Health and Adult Probation Department. I'm in partnership with our contractors, Westside Community Services and UCSF Citywide. It is also open for the last 3 months. June 9th was our grand opening, and you'll see them it's Minna Hotel. It was a former Travelers Hotel and now on Minna Street, and so now it is the Minna project. Next slide, please. This project is designed to improve the quality of life for an overlapping constituent population who are justice involved, have mental health or substance use disorder, and experiencing homelessness or in unstable housing. And people can come here for 12 to 24 months and receive dual diagnosis supportive treatment services in a responsive alcohol and drug-free transitional housing environment. Next slide, please. It also has some reentry goals, which is to reduce the barriers to transitional housing and reentry from prison or jail, and provide the behavioral health supports needed to keep people in the community rather than being over-reliant on incarceration or rearrest. Next slide, please. So let me just tell you the services. Westside Community Services, who has been a longtime contractor of Adult Probation Service Department, has taken on the responsibility of running the program. That's really everything combined, and the property management, which is janitorial and food and building, making sure the building construction. The building is still under construction. We're kind of like barely keeping head of the numbers of the rooms and the dust, and as soon as they're done, we're moving people in. They do program coordination. They're doing case management as it relates to the forensic needs. They run some process groups and psychoeducation around both health and well-being in terms of moving forward and peer support. And now we are bringing our UCSF Citywide supportive housing team on site. They started last month in September and are in the process of hiring up. So they brought over the manager of the CAS Center, which is where the outpatient adult probation services and over to this program, and they're hiring hopefully to have 2 additional, 3 total social workers, a nurse practitioner, an RN, some associate social workers, all providing clinical assessment, and so clinical case management in addition to the forensic case management provided by Westside, medications, group therapy, and really are the supportive side of this transitional housing project. Next slide, please. So as of now, we have 66 of 75 rooms complete. 6 rooms are pending furniture, and 3 more, in addition to that, are kind of waiting for the dust to settle. As of 10/14, we had 20 of 2022. That's what, about a week and a half ago, 10 days ago, we had 50 clients. We now have 44. It's been a little bit fluid. So some clients move in, then they may have a small slip. They will go to the Billie Holiday Center to have to do some sobering for a few days, then come on back. Or actually they've had clients that have already moved on to permanent housing. So while we're fluctuating around 45 to 50 and are 44 now, I actually think we've added a few more this week. We're driving quickly to admitting to 66, and we'll probably have 66 by the another week or 2. Source of admissions have been prioritized from jail, Zuckerberg, VHS services, also the forensically involved services, probation, parole, federal probation, the courts, district attorney, public defender, and residential treatment programs have received, we've received clients from them as well. And these are our 2 partners here. Probably people know by name and reputation, Steve Adami and Cedric Akbar. They've been great partners throughout this endeavor. And we're very, very proud of this program. It fills a unique niche of combining, services for dual diagnosis for those who are forensically involved. Next slide, please. This is the demographics of clients that are coming in. I think this is important to know because we've been trying to make sure that we have a diverse set of clients as a matter of addressing the diversity issues we are under Mental Health San Francisco. I'd like to say I'm very proud that this program, as well as Summarize, are extremely Spanish competent. Both at Summarize and MINA, the program directors both are bicultural, bilingual. And the MINA has already had 5 clients that have been monolingual of the 44 to 50 that they've had admitted so far. Here you see almost half are African American, a fair number of monolingual clients, Asian, Native American, Asian Pacific Islander, and Caucasian. And then gender, there's no discrimination with regards to gender or gender status. And we're proud to report a wide diversity of genders, as well as homeless status. We have 35 who have experienced or at risk, but everyone here is at risk for homelessness. Next slide. So I'd like to tell you a story. This has been pretty typical of who's come in on the earlier months of our admission. This is Lucas. He was a participant in young adult court for 3 years, during which he struggled for addiction and experienced homelessness and incarceration. He entered the Our House, which is one of adult probation's other programs, in 2020 and transitions to the Positive Directions TRP Academy run by Westside in the summer of 2021, and then made his way to the MINA project in May as a transitional housing step. Today, Lucas is off probation, living a clean and sober life, working full-time, enrolled in college, and recently attained permanent housing. So he's one of our success stories who moved on, which he moved into when he graduates from the MINA project program at the end of October. That's this month. So that's Lucas, young man, well on the way to moving forward with his life and his success. Next slide, please. The next story is Monique. After struggling with addiction and experiencing homelessness for over 20 years, Monique came to San Francisco from Albuquerque, New Mexico. In March 2022, she connected with Code Tenderloin at the Tenderloin Center and got placed in the Billie Holiday Center. From there, she transitioned to the MENA project in May and continues to stay engaged in the program, helps others, and gives back to the community. I met Monique. She's a real riot, and just really happy to have her as one of our many women in the program who've joined us on a path again to wellness and hopefully permanent housing at the end. So that's what I have on the MENA program. It's really just a snapshot. I don't have data yet because we're in the process of staffing up the clinical side, still building rooms, literally, and are now going to begin creating our evaluation structure, which will be a little more complicated. We'll want to include data from probation system and the forensic system, as well as health data. And we haven't quite figured out which are the best measures and where to get them. So if you have thoughtful ideas on measured outcomes, both forensic and health, those suggestions would be well welcomed at this point. So that's what we have.
Dr. Pating.
Welcome to take questions.
Thank you. Member Eisen, I see your hand is raised.
Yeah, thank you. Thanks for the presentation. Just in terms of base data, like even the number of admits and discharges, I mean that they must have because there's an admit and a discharge. So like how many clients on a given day or week or month or period are admitted, and then discharges from service and counting in whether they go to a short-term detox and then back to program. So those are kind of base data. I'm wondering if you can also collect information, since there were some questions, there was a commitment on the part of the department that people who are on medications of any kind would be allowed to continue their medication. If you could confirm that via data as well, since that was a question regarding, not now, but I'm talking about in terms of data reporting, number of clients who are receiving on medication, particularly individuals who have an opioid use disorder, and whether or not they have been offered an MAT, given the disproportionate number of Black African American men dying of drug overdoses in San Francisco. So, thanks.
Thank you, Member Eisen. Are there any other comments? I'm looking for hands. Okay.
So this program is right around the corner from Summarize. If you go to one, I recommend you just walk around the corner, pick up a sandwich, and walk to the other. So,
yeah.
Thank you very much.
Thank you, and thank you, Dr. Pating, for for being gracious with my request with the timing of this, and all members. Thank you for that. Ash, will you take us to public comment?
Sure thing. So again, call this number 415-655-0001, access code 2482-224-1541, and then press pound and then pound again. Let's see if there are any callers. There are no callers. I'm going to wait it out a tiny bit longer. I see a caller in the queue. I'm going to unmute you and you may begin your comment.
Hi, I just wanted to say that it really sounds like a wonderful program you've got going there. I'm curious about the Billie Holiday project. When are we going to get some mapping and a directory of all the services out there? I think it's really, really essential. Thanks.
Thank you. There are no other callers, but I am going to wait a little bit longer in case anyone calls in. All right. Since there are no callers, I am going to close public comment, and I think we are moving into a break.
Thank you, Ashlyn. Yeah, so let's break until 11:05. We'll start again at 11:05. As the caller mentioned, she's interested in mapping in a directory, and the first thing that we'll be talking about when we come back is the mapping project. So see you all at 1:05. Please go take care of yourself and turn on your camera when you return. Thank you.
Jennifer, I'm back, but I'm eating, so I'm going to stay off camera until I stop munching.
Okay, sounds good. Thank you.
Okay. And are we going to 1 today or 12?
We are going to 1.
Okay.
Yeah. Please turn on your camera when you return so we know that you are on. We'll start once we hit quorum.
Jennifer, I'm back. I'm going to be off camera for 1 more minute.
Thank you, Member Hammer. IWG members, if you're back, please turn on your camera so I know that you're here. We'll start once we have quorum. I have Member Eisen and Hammer are here. They're just off camera.
I'm back.
Thank you, Vice Chair. We need one more and then we can start. All right, we have 7 members present. Let's go to the next slide. All right. The DPH mapping project, something that I know this group is very interested in. We're looking forward to hearing an update on the project. For this, we welcome Ashley Vaughn, Heather Weisbrod, Yoon Jung Kim, and Dr. David Pading to present.
And can I, Ms. James, can I just take, I don't know, prerogative to kind of
Please.
split it up for a second?
Please do.
Thanks. So I know, I just want to acknowledge, first of all, the many requests for this work to happen and really value both the requests and the work that this then generated in the context of sort of the multiple projects and programs we are pushing forward. So I want to invite the membership to see this as iterative. This is really a first round of aiming to describe what I think will continue to evolve as sort of a public comment, document and way to talk about and think about and translate our levels of services and what we're doing. So we've been hard at work at this, and we'll look forward to really your feedback about how best to represent these data and what else you'd like to see. The other comment I just want to make is I want to just make sure everyone knows, public and in the committee, that our find treatment website is up, and that provides a list of residential care programs that are available for the public or self-referral. This is not an exhaustive list of programming that either DPH does not administer, such as the Billie Holiday Project, or some services that require there to be a level of care assessment, and it's really for people coming out of hospital or other intensive setting. So with that teeing up, I look forward to the discussion and feedback, and I'll turn us over to Ashley, who is the manager of communications within behavioral health.
Thank you, Hillary. Yes, as Hillary mentioned, I am the BHS communications manager. I use she, her pronouns, and today I'll be giving you a little bit of a deep dive into our system. Again, just reiterating what Hillary mentioned, that this is truly a work in progress. This is our first pass at the system mapping, so please consider this a draft, and we definitely welcome your feedback and comments. And you'll see as we go through the presentation that some of the slides and some of the data that we're presenting is still very much so being collated, so it's not entirely comprehensive yet. Today, I will be going over our behavioral health services, as well as the ways that MHSF is building on our existing system of care, how people can get access to those systems, and the ways in which someone may interact with our system. Next slide, please. In San Francisco, we're very lucky to have an expansive behavioral health system. We have a total annual budget of $600 million. We are the largest provider of mental health and substance use prevention, early intervention, and treatment services. And we have over 760 staff who, along with a network of 80 partners that help us deliver clinical services to about 21,000 people per year across more than 200 clinical care sites in the city. And we provide prevention and early intervention services to about 80 to 100,000 people per year. We do this, or we're able to deliver these services through our 8 systems of care, which are meeting the very specific needs of certain populations. So on this graphic to the right of the slide here, you see that we serve adults and older adults. We have a residential system of care, which you should know all about since we are expanding our new beds and facilities. We have a street-based and justice-involved system of care, which includes the street crisis response team. We have a transitional age youth system of care, which serves young adults 18 to 24 who are transitioning public systems like the foster care system. We have our substance use disorder system of care, as well as comprehensive crisis, which provides acute psychiatric evaluation and intervention services for adults and children, as well as our Hope SF wellness sites, children, youth, and family services, and our newest section, which is population behavioral health, which focuses on overdose prevention, drug user health, and non-clinical interventions. So as you can see, we really serve a very large and diverse population, and that includes people experiencing mild, moderate, and severe mental illness and substance use disorders, as well as people who are experiencing homelessness and who have stable housing, people who are in a crisis who require urgent care, as well as people who are stable and require routine care. Next slide, please. This is our continuum of mental health services, starting with prevention all the way through residential treatment and recovery. I will expand a little bit on some of these bullet points here. So our low threshold services can include our Pure Warm Line, linkage to community services, as well as our street-based behavioral health services. Our outpatient services include group individual and peer-to-peer services, as well as medication and prescription monitoring, our intensive case management and full service partnership, our intensive community services for people with severe and persistent mental illness. And we provide outreach, evaluation, and support. Of course, these are crisis services here, as well as transitional housing. Next slide, please. These are our substance use continuum of services, from primary and secondary interventions, risk reductions, which include naloxone, safe use supplies, and low threshold services as well. Our treatment and recovery services, so medication for addiction treatment, our residential treatment, as well as transitional housing. Next slide, please. Expanding upon our treatment of care, we have 2,200 residential care and treatment beds. And depending on where a person is at in their process, or they may fall along this continuum of acuity, maybe on the left-hand side, they may be highly acute, they need to be stabilized, and so they may end up in PS or psychiatric emergency services at an urgent care or an acute diversion unit. On the right-hand side, you see someone who's not very acute, who may just require stable housing, and so they would may come in through a residential step down or a shelter. And I just wanted to point out that this bed count is not reflective of our MHSF beds. Our new beds and facilities are actually tracked through our BHS bed expansion dashboard, which we update monthly, and it's available on SF.gov. Next slide, please. Here we have our substance use disorder treatment capacity and services. So we have our service type and capacity. For withdrawal management, we have a capacity of 58. For Medi-Cal reimbursed residential treatment and step-down housing, we have about 392. Our residential treatment has a capacity of 50. Outpatient substance use, which includes recovery, supports, and navigation, about 1,240. And our opioid treatment program, about 4,000. And this is for fiscal year 21 to 22. Next slide, please. We have our mental health services here. And I will just note that this is a place where we're still expanding and collating the information for these comprehensive services. And so we have our number of program by service type here. We have 32 programs in intensive case management, full service partnership, and other linkage and intensive programs. We have 56 outpatient clinics, or we don't just have one outreach and linkage program, but that's where we had started counting. And obviously the peer support programs, private provider network, and crisis teams are not comprehensive yet. So we know that we have 7 street crisis response teams. However, this is not inclusive of our mobile response teams. Next slide, please. So you may be wondering how MHSF really builds upon our existing behavioral health services. What it's intended to do is bolster our services in certain areas. Our mental health SF Prop C budget for this fiscal year is about $52 million, and for the next, it's about $62. And just as a reminder, our total annual budget for behavioral health services is about $600 per year. And MHSF is really intended to serve a very targeted demographic, so that includes adults 18 plus, folks who are experiencing homelessness, who have a serious mental illness and substance use disorder. They may be uninsured, enrolled in Medi-Cal or Healthy SF, and they may be people who are just as involved in reentering the community. And the ways that we are reaching these people or attempting to reach them are through our 4 key mental health SF strategies, which are our street crisis response teams, our mental health service center, our Office of Coordinated Care, and our new beds and facilities. And mental health SF really does touch our behavioral health system at large. The only exception to that rule is our children, youth, and family services, which it really doesn't touch upon within the system of care. And you can kind of see here that our street response teams fit in nicely in street-based and justice-involved services. Our treatment spaces fit into our residential system of care, whereas our behavioral health access programs, which we're expanding, the Office of Coordinated Care, and the Mental Health Service Center are kind of layering across and building upon the existing system. And they're, bolstering access, they're coordinating care and helping us transition folks from different levels of care. And so in the last year, we've seen Mental Health SF expand upon our street crisis response team. So we've launched 7 teams. They're providing 24/7 citywide coverage. We've expanded our behavioral health access center hours, our OBIC clinic, pharmacy, and we've also upgraded our behavioral health access line to improve call capacity and data tracking. And we've added more than 250 new residential treatment beds and facilities. The Office of Coordinated Care also launched follow-up for clients who are experiencing an involuntary psychiatric hold, also known as a 5150. The Office of Coordinated Care is also expanding on our intensive case management services, as well as bringing in new services. And just a note on the Office of Coordinated Care, it is really layering across our system and helping people with the most complex behavioral health conditions and social needs to transition between levels of care and remain engaged in our services. And this is especially important because these folks tend to be most at risk to fall out of care. Next slide, please. So you might be wondering, what does this translate into in terms of accessing services within behavioral health? And so there are many, many, many different ways that people can access the city's behavioral health systems. These are just a few of our access points, which include behavioral health services here on the right-hand side in the green, and our other access points available through service providers like the Department of Public Health, city partners, and our community providers are here listed on the left-hand side. And you can really think of these as doorways or the doors that people are entering through to get connected to care. So starting at the top with our behavioral health access programs, that includes our behavioral health access line, our behavioral health access center, our street response team, which is the street crisis team, as well as comprehensive mobile crisis. Again, those are acute psychiatric intervention and evaluation services, and our drug sobering center, so RISE. On the top left, we have street medicine, our city partners, which may include homelessness and supportive housing, human services, San Francisco Unified School District, just to name a few, community partners like after-school programs, churches, community centers, family resource centers, urgent care facilities like Door Urgent Care, Westside, our justice-involved systems, jails, adult probation, collaborative courts, our emergency room like Zuckerberg San Francisco General, and then people can also enter in through primary care. Next slide, please. So I am going to be providing a few different scenarios on how people may flow through our system. And I just want to note that this is a simplification of a very nuanced and very journey and maybe even an ideal world kind of scenario. But for each of our clients, the reality is that the journey to wellness through our system can look very different. So our first example here is a 39-year-old uninsured woman with a mental illness who is calling into the 24/7 Behavioral Health Access Center to request help. An initial screening is conducted. Her benefits and eligibility are reviewed by our staff, and it is determined that this person can be connected to care through our private provider network. In this instance, you see an MHSF Bolster program, which is our behavioral health access line, which is increasing access to our programs. The next scenario that we have is a 23-year-old man who walks into our behavioral health access center and says they want help with a substance use disorder. Again, a screening and assessment is conducted. During this process, our staff will also identify any urgent needs that this person has, whether that's a hospital discharge, or maybe this person is justice involved and reentering the community. Based off of the screening and assessment, our staff decides that they can be connected to care in the following way. So a substance use disorder withdrawal management program. This person would then receive any necessary health screenings, TB tests, or medications from our pharmacy and the opioid treatment program. And then they would spend several days in withdrawal management, where they would be then referred to a 90-day residential treatment program. Again, you see an MHSF bolstered program of our behavioral health access center, increasing access for folks to the system. Our final scenario here is a 56-year-old who is experiencing homelessness and has a behavioral health crisis in public. The street crisis response team is dispatched from 911 emergency medical dispatch to assist the individual. SERT would then meet with them, provide de-escalation, assess their needs, which can be physical, psychological, cultural, and behavioral. It is decided that this person actually needs to be transported by an ambulance to the hospital for involuntary psychiatric care, also known as a 5150. In this specific instance, if a client is transported to a hospital or an urgent care and they're acute, the Street Crisis Office of Coordinated Care team would then coordinate with that facility to meet with the individual and assess their needs and provide short-term critical case management. They would also provide community outreach and linkage to housing resources, connect this person to intensive case management services and bridge them into care, reconnect them to any existing providers and resources along the way. If they need new connections, they would also be doing that. And they would also be communicating with other street crisis response teams or street response teams and low threshold providers in the community. That is actually all that I have for you today. And I understand that that's a lot of information. It's very nuanced, and that this is something that's been highly anticipated. So I believe we do have time for some questions and answers, and we do have some folks joining me today to help answer those questions.
Yes, we do. Thank you so much for that presentation. And you will be coming back. So this is just an update and kind of a overview. So we're just kind of emphasizing that this isn't the only time for feedback, but we do have 20 minutes for this. And I see, I'll start queuing you up. I see Member Field's hands. And as we learned from the first time, maybe we can do one question at a time just to make sure that everybody has a chance to speak, and I'll continue to put you in the queue so that everyone has a chance. Member Fields. Member Fields? Member Fields, if you're speaking, I can't hear you.
Probably should join the meeting. Thank you, Ashley. Appreciate the presentation. I think it's a very good overview of for people who don't daily live within this system and try to figure out how to do. And I'm looking for the complexity to appear, but before you can get to complexity, you have to build simplicity. I have a point to make and a question. And then, so technically, back in the early slides, and this is the hard part, can you go, there was a slide where you were describing the community-based system of care. I think it was residential services. And in parentheses, your choice of examples is long-term, hospitalization, locked, etc. And I'd like to say that in MHSF, because we have an opportunity to move away from those settings. And it says something to me about the thinking of DPH, that when you want to list things, that every day I get calls from other counties saying, how do we get crisis residential like you guys? How do we get transitional residential treatment? We need those kinds of beds. We don't lead with our best story. We lead with the places we don't want people to be. I do not consider hospitals residential. I don't consider L facilities out of county, which we fought to get out of all of the 1980s and 90s. And now we're going back to that. So I'd encourage you to pick the best foot forward, which is our progressive recovery-based continuum of care beds before we get to the places we'd like people not to have to go, even though often they do. Oh, and my question is this, in your, you probably have to have 500 actual diagrams to show these pathways. So I appreciate the pathways that you've shown because I think they're accurate in their own way. But given the current conditions, because we're adding on to a system of care and enhancing a system of care, as you very articulately said, I think often, I mean, for instance, my agency runs Dorjan Care, we run crisis residential. We have very little referral from the SCIRT team. So an example that has access to the treatment systems, we aren't there yet, starting with the SCIRT team and then moving through. Our access is the same old one, which is the police picking up people on a 5150 who are living in hotels without enough support and there's nowhere else, and they're going off to PES and then being hospitalized. That still, I think, is the pathway we're trying to have an impact on through MHSF to change. And so if that's an aspirational diagram, I completely am behind it. If it's also trying to show what is now, so people aren't confused, say, how come you say, my son just got hospitalized because he was in a hotel room south of Market and he was having a psychotic episode. And it was the same process. He ended up, the police came because the SCIRT team does not go into facilities or housing. Police came, assessed him, took him to PES. He was in the hospital, and that's the only way he got into treatment. So how does that experience parallel what we're trying to alter and change? I think is the next iteration goal of this mapping project, because this seems to take what we're heading toward, and it's still not recognizing the primary patterns of hospitalization, including the role of the hospital in that whole pattern. So I'd like to encourage us to get to that level too. Thank you. But no questions, I guess just a speech. Thank you.
Are there any responses?
I
Okay,
don't know. I'm sorry, I don't know that I heard any questions in there.
Yeah.
Answer.
Okay, thank you. Thank you. Let's go to member
Maybe,
Wong
I'm
and
sorry,
then
maybe the only
Salinas.
question, Ashley, is do you understand the point I'm making? That we're not also showing what is the experience of most people still who are in our behavioral health system. They're not entering yet through some of our, and so we're talking about where we're going, but path to me, mapping includes a realistic view of what's actually occurring now and comparing it to where we're heading. Do you understand that? You don't need to do that, but that's what I'm asking. I hope that's a goal of this project eventually. That's what I'm asking.
Yes, thank you. And I have some of my own personal experience with the behavioral health system, so I totally understand where you're coming from as someone who's experienced it myself. So thank you.
Can I just also just offer a comment? And I want to get to everyone's questions, member Fields, and I suspect we'll hear others. I think part of our, just for people's awareness in doing this mapping project is I'm guessing this group and beyond will have lots of different ideas about what it should be or is supposed to be. So just eager to hear both, of course, your input, member Fields, but as well as others about how we best accomplish. I think what I'm hearing from you, member Fields, is both what is and where we're aiming for, and very much appreciate your examples or the need for use of different examples.
Thank you. Member Wong? I think member Wong dropped off. I'll keep her in the queue. Member Salinas?
My questions Because this is you know, I understand it's very preliminary. And so I think to help us understand what the, you know, overall goals that, you know, are of the mapping project, like what are next things that will be layered onto this preliminary, where are you going to be expanding? Like, for instance, this example that, you know, what would be, and you know, I think important point that Steve Fields brought up is like, what would be an ideal, if you took a client, you know, if you took just a case study, what would be an ideal movement through the continuum of care that we are aiming to achieve, you know, in the building out of our behavioral health system, you know, and the filling in, the hopeful filling in of gaps, you know, in mental health that mental health SF is meant to address, right? So you know, with what you have presented, where will you be going next with the mapping? So that, you know, I think it helps us to be able to know, you know, not ask redundant questions if you're already and to know where to point out, you know, where you might need to build a little bit, if we can just have a more sense of where you're going future with the mapping. I hope that was clear.
You know, maybe Member Salinas, maybe we can circle back to this question at the end of the questions, like have this be the last question, because I think we are doing this responsively to the IWG, and so I feel like looking to this group to help provide the feedback about what are recommended next steps. And so maybe we can circle back as this being the last question to kind of end with and to help shape what are next steps for us. Does that make sense?
Yes, because and I guess one comment that I would also have is also thinking about where does HSH fit in on the spectrum, which I know is a whole other thing, but it is, you know, the primary house, you know, for getting our folks stabilized, that is actually the primary as a very essential component, right? Is getting them into permanent supported housing, and hopefully, you know, the housing that offers on-site nursing medication management, right? And so how are they also going to fit in on this mapping, on the spectrum of care?
Thank you. Member Wong, I'm going to go back to you. Did you have your hand raised?
Yeah, and I did, and I put it down. I figure I don't want to be such a nuisance. I think part of it is that, I mean, I really appreciate, thank you so much, because I really don't do too much case management. So looking at this mapping, it really helps me understand what DPH actually has out there. I think part of what I've been asking all along is, you know, within these little little sections or categories, what entity belong in that category? So that way, if we are doing, if, as you said, Dr. Kunis, get back to the question at the end, is that how do we then help facilitate, and how do we then collaborate with DPH in what type of services, or how do we then provide that continued care for our clients or patients, you know, when they are in crisis. I mean, I really appreciate the work, because I noticed that there's a lot of work into it. But I also was thinking a little bit more, you know, what kind of entities within those categories that you have. So that way, let's just say if a case manager is needing, or anybody needing services, they would just look into this map and say, oh, in this map, here's the outpatient treatment, and in the outpatient treatment, these are the places. And then, you know, whether you want to expound on it more and say this treatment center provide da 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 da, but I think it just need a little bit more information, to help guide the process, if I'm making any sense.
Okay. Thank you, Member Wong. Eisen and then Hammer.
I think my questions are somewhat similar to Member Wong's. So I'm not quite sure, what is the length of stay? I should know this, but I don't. What is the length of stay in crisis stabilization and acute psychiatric? And then where do residential treatment not focus on substance use? Like, where do the progress programs fit in this? Under which bucket are they? And so that's like,
And Member Eisen, are you referring to the, excuse me, but are you referring to the slide that has the different beds on top?
oh yeah, you mean you can't all see what I'm looking
Yeah,
at?
maybe, why don't we go, Ashley, if you would go
Sorry.
up a little.
Page
Yeah.
63. No. Back to the one that has all the residential treatment continuum. So sorry.
Yeah. No, that's fine.
Yeah, thank you. I was like, I'm staring at it. It was like, what are you talking about? Yeah, I'm just trying to have a deeper understanding. I'll go back again to the slide that has residential continuum of care.
There
we
right
go.
there.
So when you see the crisis stabilization, acute psychiatric, what's the length of stay on those? And what are they currently? And then residential care facilities, what are those specifically in San Francisco, if you will? I just don't, like, it would help me because I know providers and I'm not sure who does this work. Because it's my recollection in this committee that there was a lot of concern, that there was earlier conversations in the committee that there was a real gap between services that couldn't exceed 23 hours and services for like a longer period of stabilization. So I'm trying to figure out under what bucket that would be. And then the final question is, which of the services currently are contracted out of county, and how many beds are out of county?
So we do have a few folks from our residential team here with us today. Maybe Yoon Jung can help answer those questions.
Sure. So happy to answer some questions. With the member Eisen. So in terms of a psychiatric emergency service, the acute hospitalization, the length of a stay. So we'll actually connect to the actually general hospital and then get the actually data back to you. So currently general hospital is not under the behavioral health services, absolutely under the DPH. So we need to get the data. So they have a really good data in terms of length of stay, discharge rate, and then discharge destination and so on. So in terms of acute diversion unit, which is also called a crisis residential program. So as a member Fields mentioned, it's a acute, run by actually, those are actually run by Progress Foundation. So there are 4 locations in the city. So its length of stay is 14 days. So it could be extended depending on clients' actually symptoms and need. So second question is, where are the residential care facilities and then are fitting into? Actually, so we do have a residential system of care under the system of care. So at behavioral health services. So that actually residential system of care used to be called transitions or placement team. So those placement team or transitions used to be under the San Francisco Health Network, not under the behavioral health services. So it's transferred actually to the behavioral health services the last year. So most of actually residential facilities, care facilities, most of the locked subacute units are actually located outside of San Francisco. We do have 2 locked subacute facilities in the city. One of them is a behavioral health center, and another one is San Francisco Healing Center. So those are actually over 95 beds. So other than that, actually all of the locked subacute beds actually are located outside of San Francisco. So Vallejo, Oakland, And then sometimes it goes to Santa Barbara County as well. So, and also some of actually residential care facilities, also known as boarding and care or assisted living, considered as long-term care. Some of them are actually located in the county, and some of them are actually located out of the county. We can get you actually exact number if we need next time.
And member Eisen, is embedded in your question, like you had mentioned, like the capacity of each one of these categories, the limitations of those categories, like if it's, you know, how many hours or in state or in city, out of city. And then I think you're kind of asking the bigger question is the pathway then between what happens after like a 23-hour. Is that right?
Yes,
Yeah.
that's exactly what I'm asking.
Yeah. So I think it's like when you think about like the different mappings that they're presenting and the
Mhm.
different opportunities there are, that might be something for the DPH team to consider is like those different ways of capacity. And then like
Yeah.
what happens after that, like where the linkage is to
Yeah,
flow,
like
just the
a
journey.
different map for a different like client
Yeah.
profile. Like what's the map for a person who's experiencing homelessness and is having a psychotic episode? I mean, so map certain critical populations. It would be helpful.
Yeah. I know that in preparation for this, DPH was looking at a lot of different types of maps that could happen. And so I think that's kind of what we're doing now is like which facet, how do you want to turn the system so you can see the different components so that you can plan effectively. So thank you for that.
Jennifer,
Member Hammer. Oh, sorry. Somebody else
Could I
said
just
something.
ask a question? Because this is so central. I don't know, there's people who can fill in that information on this committee. Do you want, it isn't necessarily all have to go into the Department of Public and then come back to us a month later. Can we use some of the expertise that's on the panel to answer a question like Vitka's question that I don't think's been answered yet, which is possible to answer? Or is this because I'm on, I can answer that question, but I'm one of the members, so do I help keep the conversation relevant or do I wait for the end? How do we use the expertise that's on the IWG to also answer these questions? Because it's not all in one place.
But Steve, I think it's important for that to be in this report. So not just verbally here, but it needs to be in this mapping in writing where everyone else that's not here on the IWG can see. So I think that's an important part also of this mapping, right? Is that we've got thousands of mental health workers, or not thousands, but hundreds that need to also be able to access this information, not just us. And so while you can verbally tell us here about the, the care that, that progress, that where progress it fits in here, it also needs to be in a writing, in a report.
I completely agree, but I'm concerned about whether that answer is forthcoming. Why not have the verbal answer and then have the follow-up? The answer to the 23-hour gap that member Eisen is referring to, that is it currently is in the crisis residential referral, which is, urgent care always confronts the 23-hour gap for urgent care intervention. You can't go over that 23-hour mark. And then in the category called open residential treatment. Those are the 90-day programs provided by Baker Places, PRC, Progress Foundation in the mental health dual diagnosis world. And those are programs limited to basically a 90-day stay with, as Jung Jung says, with the possibility for extensions when it's indicated clinically that an extension would be supportive. And then the last part of that continuum of care is the supportive housing provided within the Department of Public Health, not HSH, not coordinated entry, but co-op apartments, scattered site settings that are more treatment oriented with full case management attached to each apartment. That's the continuum of residential services within San Francisco that currently exists.
So the ask that I hear between Member Salinas and Member Fields is that there's information that this team has, that the working group has, that might be able to support DPH in the next step. So what Fields just narrated and what Member Salinas is asking for is like, can that be kind of a next step for the mapping process? So maybe can we pin that as kind of the final question that Dr. Cummins, you were saying like, let's end on that, because that might be a next step is how do we use the collective understanding and knowledge to be able to support DPH in creating what they're seeing as the continuum.
And to your question, Member Fields, you should feel very comfortable being able to talk with your other members if you have the knowledge and like want to share, and that's true for anyone else. So want to just like hold that there for you, that having conversation, if you have information to somebody's question, like y'all should be able to talk with each other about that.
Thank you, Aspen. I hope so, because there's other people in this group that can really, their experience is important to our deliberations.
Yeah. Member, and one of those people is Member Hammer. You're next.
Yeah, so I really appreciate this discussion and agree that to the extent that we can discuss things amongst the IWG members and with the DPH staff who's presenting to us, I think that that will really help us give more informed, more nuanced, more, more guidance. So what I was going to say is sort of tagging on to Member Salinas, and maybe now we are at the end of this discussion, is that just to remind us that we're the implementation working group for a legislated program that was crafted more than 3 years ago, right? And passed, a little less than 3 years ago. And it's as we all know, it's a changing environment. And I think this mapping that we asked for in order to help understand the environment better, but also I think to do a more informed, more data driven analysis of gaps and barriers within the environment. I think we need to be very engaged in making sure that what we're seeing is helping us get to that intention, which is for us to make recommendations based on what we understand, based on the data, based on what's presented to us to be the gaps and the barriers to getting people into the appropriate level of care at the right time. So I just wanted to put another plug in for that, for us being very engaged in this process of mapping, because I think it really can be I think it can give us a much deeper understanding in sort of what we've been asking for a long time.
Well, I think we've arrived at that point. So Dr. Cummins and Ms. Vaughn, like, what would be your, after hearing this and talking, and the IWG has expressed a little bit of interest in maybe doing some continued work between meetings even on this, is what would that look like? What are your thoughts?
Well, let me share my thoughts. And first of all, thank you. I'm really appreciate everyone's engagement. We would be happy to sit, and I know there's some limits about whether it's a full meeting or a subcommittee, so I need feedback on that too. We're happy to have a meeting with interested people and sort of just hash through some of the, it sounds like some missing elements, some how we might want to characterize some of the programming, or either split or lump differently. It sounds like I also heard describing some of the client, what I'll call client flow, describing that in ways we don't want, as well as what we do hope for. Those are some of the elements I heard, and I know we'll Ashley and I and others will look at notes from this meeting. I would be happy to have us interested folks meet and sort of just talk some more and get feedback if people are interested. So that's one approach. Another approach is to do this by email about getting feedback. And I feel open. I know this is a lot of time for people, but happy to do it either way. And then go back and forth with both using this feedback back to our teams, as well as engaging with IWG, and then perhaps come back to this group with sort of a version 2.0.
Yeah, thank you. So, so some of the parameters that we need to operate on is just to kind of repeat this for folks, is that we can have a discussion group. It can't go over 6. And then if we go over 6, it turns into a public meeting. But what we could do is do a discussion group. That's what we've done in the past, so that people could come together to talk about the design elements that we're mentioning, and then to source some of the data about what's going on. And that's what Member Fields was talking about, is what are the specific things that people know. That request could go out to everyone. But so we might consider, and we can follow up on this, is like a design conversation about like the different elements, and then plugging in the information, maybe a different activity. And those are things that we can start to plan for. Does that sound like a good next step, Dr. Cunnins and team? Okay. Any final comments before I see 2 raised hands, but I think that they are former hands. Okay. Thank you so much for this. I know this has been long awaited, and we really appreciate your time and all of the dedication you've put into this. It'll make the planning and the careful consideration all that much better. Thank you.
Thanks, and huge thanks to Ashley, who is, I know, listening and really worked hard on this and will continue to iterate. So thanks to everyone.
Wonderful. All right, Ashlyn, let's go to public comment, please.
All right, so those that would like to provide public comment can call this number 415-655-0001, and then access code is 2482-224-1541, and then you press pound and then pound again. I do see a caller in the queue, so I'm going to unmute them, and you may begin your comment.
Hello. I just wanted to say this presentation has kind of not given any kind of real information. As a clinician, if I have somebody that I want to discharge, to a special program, say Billie Holiday project, whatever that might be, how can I get information about the programs that are out there? It almost, in this presentation, it almost sounds like the city wants to do it backwards, which is where somebody, either the consumer, I don't know, it's not clear, calls these gatekeepers who then find out, about insurance and do another kind of an intake, which has probably already been done if they're getting help. I mean, you need a directory of services in the city, a directory, a map. I mean, this is almost like it was put together by a public relations firm instead of an entity that wants to help integrate all the programs into the mental health system. I mean, this whole thing started because there was no integration. There were all these siloed programs that nobody knew about, and I don't see any remedy to that in this mapping process. I'm hoping it's going to become a little more refined and specific. Otherwise, it's not going to really be helpful to anybody. Thank you.
Thank you. I don't see any other callers in the queue, so I think we can close public comments.
Okay. Thank you. We'll move on. I did want to note one thing that we are going to be doing with the website is thinking about ways to integrate some of the resources that are starting to be developed or that have been developed. So that includes the residential treatment dashboard and the findtreatment-sf.org, where you can find substance use residential treatment and mental health residential treatment. So hoping that our resources that we can provide on the website help to highlight some of these developments that DPH is working on. So discussion item number 7, December implementation report. So if you recall, we submitted the progress report in October. We do that annually. So every October we have a progress report that says, this is what we did, this is what happened. It goes and it gets kind of, that's the communication to the Board of Supervisors, the mayor and the director of health. This is a different one. This is a one-time report that's part of the legislation that talks about the implementation of Mental Health San Francisco and the IWG to date. And it's really to kind of cap all of the recommendations that we've done to date and to set the path for what the next part is going to be. So we had a discussion group that met between October, wait, this is October, whatever the previous month was, September, October, yeah, September and October. And it was Member Lipton, Member Wong, Member Fields, and Oksana Sherbeth from the Controller's Office, and we met to talk about what this implementation report could look like. And we're very happy that we're reporting that and getting everyone's feedback about this important report at this point. And so I'm going to turn it over to Member Lipton to report on what we discussed. Member Lipton, I don't hear you if you are talking.
Sorry, I hit the video as opposed to
yeah. Yeah, we can hear you now. Thank you.
So as Jen indicates, we had a meeting last week to discuss this report. And I think we all kind of felt that that the legislation really didn't really characterize what really the scope of this report is supposed to be. So I think we've looked at this kind of like from as a matter of first impression. And so if we can go to the next slide. I'm going to take these sort of out of order. We had a broad discussion about what is the role of the working group, and particularly item 2. We looked at from the standpoint that so far we've been primarily a responsive body. That is, we have meetings, we have items that are teed up for comment or for information or for review. But normally the agenda is coming from without, as opposed to coming from within the committee itself. And we discussed whether the IG should be considering to be more proactive as opposed to reactive. And within that, I think a primary issue, item 1, is that I think there are, at least the members on the call, felt that we should be focusing on how the system of care comes together. What's the integration? What's the communication? What's the coordination? How the system as a whole operates, rather than focusing exclusively on discrete programs as we've done before. I think all of that has to have been done. All that was in all the focusing on discrete programs was part of the design of mental health SF, particularly new programs and getting recommendations and so forth. A lot of those have been done, and the question is kind of where we go from here. We've also had discussion about how we relate to DPH and where we want to make sure that we oversee how the recommendations of the IWG are responded to, and also how we're moving forward on those recommendations. We've had a number of discussions, item 4, about the funding base, and I think that's something that very much we would like to see reflected in the report, to discuss that as a future issue, a future concern by the committee. There are a couple of comments that were made about conflicts of interest. This is more of a technical issue about on discrete programs. There are certain members who have had to conflict out, and we've, in some cases, maybe have lost some valuable expertise that would be helpful. In some cases, that may just not be avoidable. But I think going forward, if we begin to focus more on the bigger picture, the system of care, more strategic, how we can use the entire array of expertise that we have without having to grapple with conflicts of interest. This may require some discussion with the city attorney's office, but we want to look at that as well. And then finally, there was a feeling by the committee that we ought to try to have more engagement with the community and those who have a life experience with the mental health program. I think the kind of the overview of all of this is that the report, rather than focusing on what recommendations we've made to date, that were contained in the October report or the September report that was just made, really kind of focus on sort of the broader picture of where we think mental health SF is and where we think it is going, or where we believe that it should be going. I want to make further comments, and I'm going to skip ahead to the timeline and the engagement, and then we should come back, I think, to this slide. The original report, and I'm not sure how this got set up, it seemed to be more arbitrary than anything else, was to try to have a report drafted by mid-November and final by December 1. We had a discussion. We couldn't figure out why we had to adhere to that. So we have suggested that we move it to a year-end report, and we add another month so we can get a draft by December 15th. And that will discuss more broadly what the core principles ought to be in, or core components should be in the report at the November meeting, then have another discussion group, and then have a final comment on the report at the December meeting. And then one final comment that is not in the slides, and I'm throwing this out because it was discussed among the members who were on the call, is as part of the IWG's internal thinking as to how we want to proceed, is a concept of perhaps we should try to schedule a retreat of some type. Detail of that is kind of open at this point, but maybe in January to have a broader discussion without particular agenda, maybe just the entire agenda would just be try to have a conversation among the IWG members about where we are and where we want to go. This could be an entire meeting. It could be part of a meeting. It could be a separate meeting. There are a lot of logistics to work out. There are some Brown Act issues here that probably could be worked out in terms of public meetings. But that was one of the comments that was thrown out. Now, this is not to get ahead of where the members are, but I just wanted to throw that one out because it was discussed at our meeting last week about a possible direction that we may want to take. I think that pretty much covers what we discussed.
Yeah.
Whether
Member Lipton, between the current and considering are some of the background work that the controller's office is doing on kind of figuring out like what's possible with different things, like with pushing the report and with figuring out about like the possibility of a retreat and if it could be in person, or all of those things is something that the controller's office is working on. So just wanted to touch in with Oksana to see if there's anything in addition to what Member Lipton shared that would be helpful to the group before we go back and open it up for group discussion.
Good idea.
Yeah, thanks all. I think Member Lipton said it all, but there are a few things in terms of kind of in-person meetings that are to be considered. But I think primarily what we hope that this body thinks about is just kind of what would be the agenda for this type of retreat, and just thinking about again whether something in person would be conducive to sort of looking internally at as an example IWG's the 10 principles that you all kind of view all of the domains by using that as a framework. And so again, don't want to dive too deep into that, but just to say that logistically it would be possible to do kind of an in-person retreat, but very much pending if that would be useful and conducive to what would be on the agenda. But without kind of diving too deep into it, it might be something separate from an IWG meeting. It might be kind of as an addendum to an IWG meeting. So it's a little bit difficult to speak in vagaries, but just wanting to put that out there so that it's top of mind for future end of year.
Yeah. Thank you, Oksana. Member Fields or Member Wong, is there anything to add before we open it up? For you were part of this discussion with.
No, I would just want to understand two things or add a couple of things. The report that we received from Oksana was, if it hadn't been as good as it was, it wouldn't have been the basis to trigger some of this. So I think, and then her response, I think, has been real helpful for us to galvanize some of the thinking that I know is among other members of the IWG that have talked to me but couldn't participate in this committee. And then I don't think anyone, Steve didn't miss anything in his summary. So I think it was a complete and really helpful statement of an important point in the evolution and the development of the IWG. I mean, I guess what I'd like to add is we all know that we got started after things that had to get started in the department already were underway. We recognize in this discussion that there are crises happening that no one controls, and we were, because of the delay in getting the IWG impaneled, we had the difficulty of the Department of Public Health certainly couldn't wait to address some of the issues that we were all addressing on the streets that were inherently a part of what this legislation called for. And I think what happened with that is we were playing catch up with specifics, as Steve refers to in his report, the specific program model, which to some degree, the programs aren't being criticized, but the idea of how they fit into a system of care. What's our vision? Where are we really heading? What's the goal of MHSF in the view of the IWG? And maybe it's in conflict in some minor ways with the mayor's office or the Department of Public Health, but where are we heading? How are these, and it's inherent also in the discussion we had around mapping, how does it fit into the system we have and how we're altering it or affecting it to be more responsive to our clients across the board? And this idea of having to review individual programs that the department people are working so hard on and really doing an incredible job of standing up is still missing the big picture. Sometimes there's a feeling that we're being asked to respond to the trees in this forest without there being a place for us to talk about the forest and how these relate to one another. And I'm hoping, and I think the people on the committee were hoping that that's a part of our evolution as a group that goes next, that we find a way to emphasize the system of care that these specific programs are coming into and presumably enhancing. And not just get reports and only from what the work that the department folks are doing on these particular specific programs. So,
Thank you.
that's
Before Member Wong, anything to add?
No, I think both Steves had just articulated everything. And I do want to point out, on this, the progress report on this item here, it says I don't know if it is an error. It says, if you look at the overages of the thing, it's 1413.2. Is that an error, Mira? I don't know how to read that.
Okay, we can come back to that, Member Wong. I'll follow up with you after this meeting.
Yeah, but actually, I think that, Member Phil had encapsulated everything. And thank you, Steve Lipton, for summarizing it. And yeah, it was a very productive meeting. And I hope that we can actually kind of see how we as a IWG group can really kind of help move along, with DPH on this mental health SF. Yeah.
Okay. So why don't we open it up to the rest of the IWG? And Ash, if you could go, we have probably 2 lines of conversation to have in the next half hour or so. One is, one slide up. One is kind of those key opportunities. And so the way that we're going to develop this report, depending on how fast or we need to move, if we can get an extension, is to be able to include you all in the development of the report and to get your feedback. And so this group started with these 6 different key opportunities that they identified through discussion as opportunities to extend on. And I don't think we want to go down a very deep discussion of unpacking each one, but we did want to check and temperature check, do these 6 resonate with you? And is there something, and we can work on detailing it through our process. But do these 6 resonate with you is one question. And the second question is, what else is missing that we should be thinking about as we start to develop this report? And again, bringing it back to you, but we have this time together. So do they resonate? Anything that's missing?
I would say I think this is a very good list for us to start with of moving how to shape our work moving forward.
Thank you.
I would agree.
Okay.
I agree too. I just, the number 2, the shift from responsive to strategic. I want to say again, like just, we have a legislated program to advise on its implementation. And so I want to make sure that we all agree what we mean by strategic. So that we, so that we're all swimming in the same direction and
Yeah.
make the best use of our time.
Thank you, Member Hambert. That's one of the things that we've been talking about, I think, throughout this probably the last couple of years, or the last couple of months for sure, is the sphere of influence of, and being clear on what the sphere of influence of this group is. And so this might help to clarify that and speak to what really advisory means.
Jen, can I comment on that?
Please do.
Okay. We're, as a committee, the IWG will have to continue to be responsive in some respects, as I think Member Hammer just mentioned. We are going to have programs that will come before us that we're going to be asked to provide assistance in terms of development, or in more cases as we go forward in terms of oversight. So I think that's a function that the IWG will have to continue to do. But I think the broader focus is that we also should be thinking more strategically as to how the pieces come together, and that's the strategic side. So it's not a 100% shift from responsive to strategic, but it's a gradual shift, and whereby you'll have pieces of both that the committee would be involved with.
Member
That
Fields?
makes a lot of sense.
Yeah. Member Fields, I think your hand is raised. Just want to make sure you have space. No, I can't hear. You're muted.
Trying to get work done. If somebody else's hand is up, I will certainly defer.
Go ahead. I'm watching.
Okay. To me, the meaning behind the responsive to strategic goes back to the origin. I just want to, I always end up going back to context when I do this. The premise that was in the public discussion when this piece of legislation was discussed and developed in collaboration between the Board of Supervisors initiatives and the mayor's initiatives was that our behavioral health, our mental health system was broken. And there were all kinds of, very strong and not inaccurate adjectives attached to it. I think the public was nodding their heads yes from their perceptive of things. So to me, strategic means this legislation is fundamentally strategic. It's not about what little pieces are missing from it, but how do we get the sense of support from the community at large that we're moving toward a strategy of discussing an organized behavioral health care system that's comprehensive and interrelated and interlocking. That's strategic, and from my mind at this point. And I think we have that obligation to the legislation is to look at, when we're at the end of this process, can we say in our role in this that we were participating in trying to address and repair and improve on the system of care, not just by doing new programs that we would probably all agree that we need as a part of that solution. And that to me is strategic. And that's the part I think we've had missing. We want to be collaborative with the Department of Public Health. And I think the discussions around the services center, I think the discussions that emerged today in terms of looking forward, that's our role, is to collaborate. We know who makes the decisions and we know where they emerge from. But advisory for history in San Francisco has been viewed by those people on those bodies. If I'm just here to advise, or am I here, my advice includes trying to push things forward. And that's what I believe we're here to do. And I think we can't underestimate the importance of number 4. Because when this whole process started, there was not an intention that our economy would be such in the city that we were going to have to draw on Prop C funding for most of the implementation of MHSF. Those of us who work in the political reality every day in San Francisco, now it's created a tension with our allies who are supporting generalized services for the homeless. And I think one of the things we need to look at down the road is we can't let, one of the great things about being advisory is you don't have to implement it. We can't let the fact that we're limited right now in looking for the resources to stand up the programs we need from continuing to describe what that need looks like. And then I would argue fighting for the revenue to make it happen and not just relying on Prop C. And that's a political discussion that's gone on for ages in San Francisco, but I think it's the important one. We can't afford to scale back our vision in favor of reality. Otherwise, we don't know where we're heading or what the prioritization is for what comes first, what comes second. And I think that's still on the agenda. And I believe that's where we, working in collaboration with the health department, can actually continue to envision where we're heading without being limited by the kinds of realities that impinge on us all the time. So.
Yeah, thank you. And I see Vice Chair Patterson hands is risen, but does anybody have a response to Steve before we go on? Or a question? Vice Chair Patterson?
Do I have a response?
You do. You have the floor for whatever you want it to be.
Oh no, it's okay. It's okay. We can move on.
No, please, please. This is your space.
Well, again, I feel like I'm not sure if we've done inventory or enough inventory of the system that we have, what's working and what's not working. And so, I think, a lot of it starts right there. And then I'm not sure if, we've examined mental health, altogether, because there's still a stigma that mental health is crazy. And it's not just crazy. I think a lot of us deal with mental health. Something that's interesting is the mental health aspect bleeds into a lot of systems. Like it's involved with the shelter system. It's involved with the drug treatment system. Then you got people who just purely suffer from chemical imbalance. Mentally, they're not on drugs. And so I don't know if we've quite had that kind of examination. So I'll leave it there. But there's a lot of different parts in the city. I mean, there's a mental health, there's a mental health clinic in Bayview that people didn't even know about. So it's like stuff like that. I mean,
Yeah.
have we even looked at all of the mental health facilities throughout the city and what they provide?
Yeah.
And what location and in what parts of the city have mental health locations and what parts don't? But I land the plane there.
Yeah. Yeah. And I think Vice Chair Patterson, one of the things that you're lifting up is, in addition to the mapping, connecting to the previous conversation, is some of the mapping things we talked about. We didn't yet talk about like what the mapping looks like when you put it in respect to where location and accessibility is. So that's another important consideration that connects both to planning, which is what we're talking about now, and to the mapping, which is what we just talked about. So I appreciate you bringing that up. Other comments about just these key opportunities? It sounds like the 6 key opportunities are good and we can start to build on those. Is there anything that's missing? Okay, could we go to the next slide then? And again, like this is a first time conversation for many of you. This is the first time you've seen those 6. So I'm sure that after the meeting, many things will come up for you, and you're always welcome to write us to get involved in the discussion group that we're going to be talking about all of those things. I wondered, Oksana, do we know at what point we'll have an answer, or do you have a feel for when we'll have an answer about when we might know about if we can extend the timeline?
Yeah, the one concern is we were hoping to field this idea with our chair, who is unfortunately having a kind of a medical situation going on. So I think that was, that was our next step. But hoping, within this week to decide, hopefully by end of week. I think we should operate as if the due date will be December 1st, but again, hoping to provide a more definitive answer by end of week on whether that extension will be pursued.
Yeah. Thank you. And I appreciate you bringing the spirit of Chair Lassar into this, is because she'll also, like when we talk about the meeting, the retreat next month, all of those things is we do need the input of the chair for all of this that we're doing. If we are able to extend, I think just testing out this process and seeing if there's any feedback or any questions about it, if we are able to extend, if that seems like that's a good idea and that's where we want to go with this, which we will know by the end of this week, we're thinking there will be a discussion group. So the 3 members that have participated in the first one, they've agreed to carry through. So thank you very much to all 3 of you for that, to start to build out these 6 points. And also to draft a member assessment. And the member assessment is what Steve L. What he referred to, and that's really kind of just a top line assessment. We were thinking we could use it to gauge with all of you about what kind of progress we've made towards those 10 different principles that we put in place, what kind of progress those might apply to the different components that we designed, and just some additional information. So that would be collected from everyone. We'd be able to bring that information to the November 15th meeting. At the 15th meeting, we'd have a discussion about the results, be able to lend some additional context to that, and we'd be listening to be able to include it in the report. So our team will be kind of collecting that information and then integrating it into the report. There would be a second discussion group about what we integrated. So they would be kind of our first line of reviewing it and saying, yes, that seems like that's right. And then we would actually send out the report to everyone for an asynchronous review, meaning we'll post it somewhere. People can individually look at it and provide feedback without running into Brown Act issues. But we did want to make sure that this was representative and everybody had a chance to put their eyes on it if they so choose. That draft for the IWG would need to be completed by December 2nd. We're running up against the holiday schedule, and we want to give DPH ample time to review it in advance of the December meeting itself, when it's kind of the big unveiling. And then it'll be submitted by the final by December 31st. From that description that I gave you, is there any kind of, is there any correction for the discussion group? Is there any correction you would offer? And for the rest of you, is there any additional thoughts that you have or hesitations or concerns you have about this process? I'm hearing no corrections. Are there any concerns or, oh, Member Lipton, did you have a? Okay, no, I saw you wound up. Okay. Okay, so our team.
Again, I think you've worn us out today.
Well, so what we'll do is we will, our team is going to start moving forward on these 6 different topics and starting to put some flesh on them based on what kind of things we've heard over the year. And we'll be, as Oksana advised, we will be moving forward as if we have a deadline of November 15th. But we will also be engaging the discussion group before November 15th meeting to talk about whatever it is that we develop. And you are all welcome to join that group. So if you want to join the Steve Squares and not that you're square, but Steve Squared and Member Wong, you're welcome to join us. We'll put that invitation out and then we'll go from there. You'll hear from us whether or not we got the extension approved. Okay. Ash, why don't you take us to public comment?
All right, so public comment, anyone who'd like to provide comment should call that number 415-655-0001. Access code for today, 2482-224-1541. Then you press pound and then pound again. And then you'll dial *3 to line up to speak. Let's see if we have any callers. Currently no callers, but we'll wait a few more seconds. All right, so since there are no callers in the queue, we're going to close public comment and going to do this last round of public comment for any other matter within the jurisdiction of the committee that's not on today's agenda. So 415-655-0001, access code 2482-224-1541. Let me press pound and then pound again. No callers yet. All right. Since there aren't any callers, I'm going to close this last round of public comment. And back to you, Jen.
Great. All right. So we continue we're almost at a point where we're going to have to start a new calendar. But for now, we know that upcoming in November, at our November meeting, we'll be having some updates from the crisis unit, perhaps the MENA project and the Office of Coordinated Care. We anticipate that we're going to continue our discussion of the Mental Health Service Center, and we'll reserve some time for the December implementation report. As always, these topics move a little bit as different things come up and we need to shuffle things around, but this is the plan for now. Next slide, Ash. Next meeting dates and time. One of the things, we're having 2 discussion groups, and actually I neglected to put the report discussion group in there, which we just discussed, but we're going to have a discussion group about the December report. So that meeting will go out and it'll be key to the 3 members' calendars, and then everyone will also be invited to come. There's going to be another discussion group that is about the wage and staffing analysis that the city is working on, or the controller's office is working on. Oksana, do you have any additional information to share about that?
No additional information. We're trying to tee up a discussion group now so that it informs the update that will be given in December.
So that'll go out as well. And so unlike the December implementation report, where we're going to be calendaring according to the 3 members' existing calendars, this one we'll be taking volunteers this week so that we know who is interested in participating in that one. And then we'll do our usual thing where we send out some kind of scheduler to try to find a date that works for the people who are interested. Note that we settled on a new standing meeting date, which is November 15th because of the Thanksgiving holiday. And so that is moved up to November 15th. And as always, the meeting minutes, all the information will be drafted and then posted onto the website. And we always have that email address for public input. Oksana maintains it and looks out for it. So if there are things that people want to note or for us to bring to this group, that's the place to do it. And that's it, my dear folks.
Jennifer, can I
yes,
ask one quick question on the calendar?
please.
I
Do you
don't
wanna
see.
Would you go back up there just so we?
Yeah.
Thank you.
It's just so much listening. I don't see it. I don't see where were you standing on the crisis stabilization unit. Early, we had discussions about it. And
They should be.
I'm
They should
sorry,
be coming
Sarah,
in.
I'm sorry. I see it as crisis unit.
Yes. Yes.
Yeah. Okay.
Yeah.
So
Okay.
we were doing something. We didn't get anything today on that, but we'll in the report.
Yeah, but you will get it in November. Yes.
Yeah.
Yeah. Thank you. Thank you for asking that.
Jen, if I can just add one more thing to the calendar. So another item that will be on the November docket will be a presentation on the kind of full system of care case management expansion. And that will be presented by Max Roca as well as Heather Weisbrod. So that'll be a larger kind of broader context into case management expansion. So doesn't flow exactly with our meeting calendar list, but just wanted you all to know that that's coming down the pike.
Thank you, Oksana. All right, so back down to the adjourning. So thank you all. Could I have a motion to adjourn?
So moved.
That was Member Fields, a second.
Seconded.
Was that Member Short? Member Hammer?
Eisen.
Member Eisen?
The other, Eisen, yes.
Thank you. Thank you. And thank you, everyone. Hope you have a wonderful rest of your day and month. And we will see you on November 15th. Thank you all.
Thank you.